Hey guys, waiting for the stream to go live. Right. So I guess all of you can see me now. Hi Tejas, I can read your chat as well. So today's class, guys, is a very special class. I'll tell you why. Okay. So this is a special MCQ marathon. This is not a special MCQ marathon class. This is a special first prof marathon class, right? Now, what do I mean by that? What do I mean by that? And why is this session titled Do or Die? Right? This session is specifically for students who are in the first prof MBBS and either they're preparing for some of their internal examinations or for their prof examinations for the upper limb. Right? So this class is for you all. And why is it a special class? Because this class is going to include all the important questions that you need to do from upper limb. It is basically a one shot attempt at completing the upper limb and that too from scratch. अगर पहले कुछ नहीं पढ़ा है पूरा time waste किया है कोई बात नहीं, just go ahead and watch this class and that should suffice for at least for you guys to pass the internals or the prof examinations. Pass छोड़ो 60% 70% भी आ जाएंगे, right? Don't worry about that. But the important thing again that is going to be our focus here is going to be your concepts. Our focus is going to be your concepts. Rest, whatever you have to memorize, I will give you the notes and you can memorize it from there directly, right? And why is it a marathon class? Because see, otherwise upper limb takes around, if you read it from scratch in detail, it takes around at least 1 week to read, right? But we are going to try and do that in around less than 1 day. Okay, basically 1 day we are going to do it in a few hours, right? So that is why it is going to be a marathon class. Welcome to Let's Crack NEET PG, the YouTube channel of Unacademy, the NEET PG division. My name is Chetanya Mittal. I am pursuing my MBBS from AIMS, New Delhi, All India Institute of Medical Sciences, right? And I'm going to talk about upper limb in today's class. It's a series for those in the first prof. Even if you have not begun your first prof, this class will be useful for you. Even if you have just taken admission into your MBBS college, this class will be useful to you. And if you are preparing for your prof or internals, this class is a must do or die class for you, right? Okay. So let's go ahead, and I would request you all to download the Unacademy learning app if you haven't done that already. You have to do that. You have to log in with your login details. You have to unlock free plan. Okay, there is a option to get a free plan from there. Okay, free plan may you require a referral code. You can use my referral code Chetanya10. Okay, Chetanya is my name and 10 is the percentage discount that you will get on any subscription that you get on Unacademy. Top educators are teaching on Unacademy live for you, and there are special classes there on Unacademy which are basically free of cost live classes that are provided to you, right? And this is my Unacademy profile link. The link is also there in the description. Go to the description and click on the link and you can visit my Unacademy profile and you can see all the special classes that I have made for you, and you can see which class you want to watch and prepare accordingly, right? So then there are capsule courses and plus courses that are there on Unacademy Plus, and these are available if you purchase a subscription. So these are high quality courses, and for example, I have covered the GI physiology completely in 8 hours, right? In 8 hours, I have covered entire gastrointestinal physiology, all the concepts, all the important points that you need to know for your NEET PG as well as for your prof examinations. Then there are batches going on. So guys, from 1st January, INI CET batch is starting on Unacademy, and if you are preparing for INI CET May 2020, do take the subscription. That is, I'll tell you about which subscription you have to take. And then there are free mock tests on Unacademy. You can see which mock test to attempt. Okay. Hi Pooja, hi Ashwarya, I can read your chat. So if you have any doubts, any questions, you can write that in the chat and you can ask anything basically. So you know why Unacademy is a great way to learn, and you will feel like you are in the classroom because Unacademy has a very robust chat feature with interactive polls. Okay, so just go ahead and install the Unacademy learning app. Don't be lazy about it. Now I have to tell you about the Iconic subscription. Iconic subscription is the subscription I think that you should take. So it has the best of Unacademy as well as the best of Prep Ladder, right? You know what is Prep Ladder? India's largest online medical learning platform. This is India's overall largest learning platform. So Unacademy recently acquired Prep Ladder for 50 million US dollars, है ना? तो अभी खरीदा है तो अब साथ में सब्सक्रिप्शन भी दे रहे हैं. So where you are getting at a discounted price everything, the video lectures of Prep Ladder, the question bank of Prep Ladder, the rapid revision course and the handwritten notes, everything that is there on Prep Ladder, right? So the Iconic subscription for 1 year and 2 year is the one that you should take, and 55,000 is for the cost for 1 year, 77,000 is the cost for 2 years, right? Chetanya 10 is the referral code that you will apply and you will get an additional 10% off. Now there are a few things that other educators won't tell you. First of all, that there is an option of no cost EMI. There is an option of no cost EMI. So please do avail that because there is no harm in taking it. Okay, you can take it through a debit card or a credit card. Then the second thing is you have to apply credits, and these credits can help you get additional discount. These credits can help you get additional discount, right? And for Unacademy Plus, there is a 1 year plan, there is a 2 year plan. Okay, you can take these plans and you can again apply the referral code Chetanya 10 and get an additional 10% off over all courses, right? So just apply this referral code, apply credits, and you can not only use this for a NEET PG subscription, but if you know anyone who is taking any other subscription, NEET UG, UPSC, etc., can use this particular referral code. All right. So let's start with today's class. So like I told you, I will send the notes for this also on my Telegram channel. So you can subscribe to the Telegram channel at the rate Unacademy. NEET PG Chetanya, right? And the Telegram channel for this particular YouTube channel, it is there in the description. It is at the rate Let's Crack NEET PG. At the rate Let's Crack NEET PG. Okay. Oh, I'll just put the link in the chat as well. Guys, before I begin the class, I want to know you all are ready for the class. Just hit the like button on this video. Just hit the like button on this video. That I know that you all are ready and prepped up for this class. ठीक है? बाद में dislike कर देना अगर मन हुआ. Do we begin? Yes or no तो बोल दो. Can I get a yes or no? Cool. So we have 11 likes and we have 14 people who are watching live right now. So let's start with lymphatic drainage of the breast. The first question that is there in the upper limb that you have to do is lymphatic drainage of the breast. So I have told you that these are your must do questions for your internals, for your prof examinations, for your NEET PG. These are your must do or die questions. Okay? Just do these questions. Just memorize these questions, just understand them by heart, and that should be enough for you. Okay. First, we are going to talk about lymphatic drainage of the breast. First of all, why is it important to know about the lymphatic drainage of the breast? The reason is that there are so many breast cancers. The breast cancer is such a common occurrence, such a common pathology. And this breast cancer, it spreads via lymphatics to regional lymph nodes. So when you remove the breast, you also have to remove these lymph nodes to prevent the spread of this cancer, right? So that is why it is very important to know about the lymphatic drainage of the breast, right? So first, when you begin to describe the lymphatic drainage of the breast, you will tell two things. First, you will tell about superficial and deep lymphatics, and you will tell about the lymph nodes. You will tell about the lymph nodes, right? So when you talk about the lymph nodes, these are known as the axillary group of lymph nodes. There are the parasternal or the internal thoracic group of lymph nodes, and there are some other lymph nodes as well. Okay, the main group of lymph nodes are the axillary lymph nodes. The main group of lymph nodes are the axillary lymph nodes. Before that, I'll tell you about superficial and deep lymphatics. So superficial lymphatics include the lymphatics of the skin, except the nipple and the areola. Important. Nipple and areola, they are part of the deep lymphatics. They are part of the deep lymphatics. Superficial lymphatics, they will pass radially to the surrounding lymph nodes. And that is what you need to know about the superficial lymphatics. They will go mainly to the axillary and anterior thoracic group of lymph nodes. Okay? So 75% of the lymph, it goes to the axillary lymph nodes. 20% of it goes to the anterior thoracic or the internal intercostal lymph nodes. And 5% it goes to the posterior intercostal. 5% it goes to the posterior intercostal lymph nodes. And mostly it goes to the anterior group of axillary lymph nodes. I'll just show you which are the groups in the axillary lymph nodes. So have a look here. This is how the breast is divided in its drainage. So first of all, what you will do is you will divide the breast into 4 quadrants. You will divide it into 4 quadrants. Okay? Upper lateral, upper medial, lower lateral and lower medial. Then the lateral side mainly drains to the axillary group of lymph nodes. The lateral side, it drains mainly to the axillary group of lymph nodes. Okay? And some part of it also goes to the posterior intercostal group of lymph nodes. Okay? Whereas the medial side, it drains mostly to the internal mammary lymph nodes, mostly to the internal mammary or the internal thoracic lymph nodes, which are along the internal thoracic vessels. Okay? Of the same side as well as of the opposite side. Okay? There is contralateral drainage. It drains to both sides, the left and the right. Okay? The left breast, the medial side, it drains to the left and the right, both sides. Okay? And the lower medial, they also drain to the subperitoneal lymph plexus, and through that they can also go till the ovary. Through that they can also go till the ovary in the abdomen. Okay? So this is what you will describe when you describe the lymphatic drainage of the breast. You will describe the lateral side, you will describe the medial side, and you will describe the subperitoneal lymph plexus here. Okay? So you have to mention all the lymph nodes: posterior intercostal, axillary group of lymph nodes, internal mammary group of lymph nodes, right? In the axillary group of lymph nodes, you further have 5 groups. In the axillary lymph nodes, you have 5 groups. In the axillary lymph nodes, you have how many groups? 5 groups. What are the 5 groups in the axillary lymph nodes? Okay. First, the most important ones, the anterior ones, right? These are the anterior ones, the anterior or the pectoral group of lymph nodes. They are the most important ones. So most of it goes to the anterior. Some of it also goes to the posterior. Then the anterior and posterior, they will drain into the central and lateral group of lymph nodes. And then ultimately that will go to the deltopectoral and finally to the apical group of axillary lymph nodes. So what is the flow of lymph? If I tell you about the flow of lymph in the axillary group of lymph nodes, first it goes to the anterior and posterior group of lymph nodes. Okay. Then anterior and posterior, they will go into the central and lateral group of lymph nodes. Then this lymph, it will go through to the apical group of lymph nodes via the deltopectoral. Okay, so these are the main 5 lymph nodes that you have to remember: anterior, posterior, central, lateral and apical. These are the axillary group of lymph nodes. These are the axillary groups of lymph nodes. Done? Crystal clear? There should be no doubt about the lymphatic drainage of the breast in your head now. Okay, so we have covered it in pretty great detail. ठीक है, अब थोड़ा सा जल्दी से आंसर देख लो क्या लिखना है. Mainly what you will do is, I told you, write superficial lymphatics, write deep lymphatics, write the lymph nodes, write axillary, anterior thoracic and posterior intercostal, definitely. Besides that, there are some additional lymph nodes that you can write. Then you will write about this superficial and deep lymphatics, like I told you. Then you will write the percentage of drainage, okay? And then finally you will draw this diagram. Very simple to draw. Just like I told you, you will draw lateral side, you will draw medial side. Lateral will go to axillary, medial will go to internal thoracic. Some part of lateral will also go to posterior intercostal. Some part of medial will also go to subperitoneal limb plexus. So very simple to understand, very simple to draw, right? And the axillary nodes, they will further drain into the subclavian trunks. Chhod do ye baatein. These are not for you. You can leave these, right? You can read these later if you want. Then finally, the apical group of lymph nodes, they will go into the supraclavicular group of lymph nodes, which are present above the clavicle. Above the clavicle, here you have supraclavicular groups of lymph nodes, right? Okay, and the lymph plexus, that is the deep lymphatics. The deep lymphatics, they will form a lymph plexus, and that is known as subareolar plexus of Sappi. Subareolar plexus of Sappi. So I will write this as Sappi plexus. Okay. Okay, right. And the most commonly involved in carcinoma of the breast are the anterior and central group of lymph nodes. They are more commonly involved in carcinoma or CA breast. You write carcinoma of breast as CA breast. Carcinoma of breast. Okay, they are more commonly involved in carcinoma of breast. So that's how I remember it. Central and anterior are more commonly involved in CA breast, right? Then there is something about radial incisions. They are done to drain breast abscesses. Why are they done in a radial way? Because here you have the lactiferous ducts running like this. Here you have the lactiferous ducts running. So you don't want to cut these lactiferous ducts. Therefore, you make incisions that are radial in nature. To drain abscesses. Okay? And this is the axillary group of lymph nodes. You can have a look at them. The anterior axillary group of lymph nodes are called as pectoral group of lymph nodes. Posterior ones are known as subscapular group of lymph nodes. Parasternal are anterior thoracic group of lymph nodes. Lateral axillary are along the shaft of the humerus, so they are called as humeral group of lymph nodes. Then the apical group of lymph nodes are called as subclavian group of lymph nodes. And then you have supraclavicular lymph nodes. Okay, the anterior group is related to the lateral thoracic vessels, posterior group is related to the subscapular vessels, and the lateral group lies posterior-medial to the axillary vein. Okay, so I told you how the lateral quadrant drains, how the medial quadrant drains. Okay, ये बता दिया ना, lateral quadrant drains to anterior axillary and anterior thoracic. Medial quadrant, it drains to the anterior thoracic, and it also has contralateral communications. Okay. So we'll move on to the second question, that is about the clinical anatomy of the breast. This is the second do or die question. First question is done. Okay. So we are on to the second question, do or die, right? So did you like the explanation of the first question? Is there any doubt that you have remaining? Okay. I hope that this diagram clarified everything for you. This diagram should have clarified everything for you. Am I right? Is everything clear? Absolutely clear. You should have absolute clarity. Any doubts so far? Okay, great. So I'll move ahead to clinical anatomy of the breast. So now if you've ever opened my Unacademy page, there is a lecture called as A to Z clinical anatomy of the breast. Alright. So this next question is basically made from that lecture, A to Z clinical anatomy of the breast, where I have covered 26 clinical anatomy points, where I have compiled over 26 clinical anatomy points. They are not only going to be useful here, they're going to be useful throughout your MBBS, whether it be for your obs, gynae and everything. These are all going to remain important points. Okay, so the first point is, so I'll do a very quick, okay? The deep areolar plexus of Sappi, it drains mainly directly to the anterior group of axillary lymph nodes. Tanya Shafi, does that answer your question? See, the Sappi group of lymph plexus, it is the deep lymphatics, and it drains mainly again to the anterior group of axillary lymph nodes, right? So I will do a rapid fire of this 26 clinical anatomy points. स्टेज बताऊंगा. You have to be very quick in grasping it. Okay, I will go really fast through these 26 points. To be really quick in grasping it. Okay, chalo. Okay, rapid fire starts now. Point number A. Upper and outer quadrant is site of over 60% of carcinoma. It is the most frequent site of carcinoma. What is the upper and outer quadrant? The upper lateral quadrant, right? So if this is the left breast, this is the upper and lateral quadrant. Upper and lateral quadrant. This is the most common site of breast carcinoma, right? Second point, rapid fire. B. First lymph node which drains the tumor bearing area is called as the sentinel lymph node, which is called as the sentinel lymph node. So if this is where the tumor is, see, this is the upper lateral quadrant. So this is first drained by the anterior axillary group of lymph nodes. So this will be the sentinel or the first lymph node that drains the area. This is the sentinel lymph node. Okay, it's very important because this is the first lymph node where you will have the presence of cancer cells. Third point, abscesses may form in the breast and they will require drainage. You will drain it radially to avoid cutting lactiferous ducts. You will drain it radially to avoid cutting lactiferous ducts, because if you cut the lactiferous ducts, you are breaking a lobule and the cancer and the abscess may also spread to other lobules. So abscesses are drained radially. This is the third point. Fourth point, so you can see here radial incisions. So these are lobules shown. These are lobules. These are lobules which are shown to you, and these small ducts, these are lactiferous ducts. So you will make an incision that passes between the lobules. You will make an incision that passes between the lobules to drain an abscess. To drain an abscess. All right. The reason is because the lobes are oriented radially around the areola. Let's move ahead. Point number D. Okay, very quickly. If cancer cells infiltrate suspensory ligaments, there will be fixation of the breast, and that will cause contraction of the ligaments, which will cause dimpling of skin, retraction, puckering, or dimpling of the skin, right? So you can see here, this is dimpling of the skin that is shown to you. Point number E, retraction of the nipple. If there is infiltration of lactiferous ducts, they will go to nipple. They are going to nipple. So there will be infiltration of lactiferous ducts and consequent fibrosis that will cause retraction of the nipple. That is, the nipple goes inside. This is the normal nipple. This is the retracted nipple. Cool. Point number F. If there is obstruction of the superficial lymph vessels, there will be edema. Cancer cells will produce what? Edema. Why? Because there is blockage of lymphatic vessels, and that will give rise to an appearance like the skin of an orange. That will give rise to the appearance of skin of an orange, that is known as peau d'orange. What is peau d'orange? Peau d'orange, right? That is appearance like that of the skin of an orange. All right. This is peau d'orange. All right. Is this clear to you? Is this clear to all of you? Point number G. Because of contralateral communications of the superficial lymphatics across the midline, cancer may spread from one breast to the another. So you can see here that from the medial side, the lymphatics of the right breast, they are also going to the left internal thoracic nodes. I have also told you this during the lymph drainage. So they can go contralaterally. So there is a possibility of contralateral spread. Breast cancer can go from the right breast to the left breast, right? Next, question number H, point number H. Because of communications of the lymph vessels with those in the abdomen, cancer of the breast may spread to the liver and they may drop into the pelvis. So see here, since the breast, it goes to the subperitoneal lymph plexus, the cancer, if the cancer is here, it may travel via this lymph plexus and drop. What do you mean by drop? It will come here into the pelvis. It will come here into the pelvis where you have the ovary. So this is drop of cancer, and that is known as, such a tumor is known as Krukenberg's tumor of the ovary. Such a tumor is known as Krukenberg's tumor of the ovary. Point number I. Apart from lymphatics, cancer may also spread through segmental veins, and such veins are the veins of the vertebral venous plexus, and they may spread to the vertebra and to the brain. So if a cancer is spreading to the vertebra, it is generally due to the vertebral venous plexus of veins, right? So you can see here. Okay. Next, point J, carcinoma. It usually arises from the epithelium of large ducts. Usually breast cancer is due to the is a epithelial cancer. Point K is regarding self-examination of the breast. You inspect symmetry, you see the skin color, you look for retraction of nipple, you look from discharge from nipple, you will palpate all the four quadrants for any lumps, and you will also palpate the axillary group of lymph nodes to see if there is any lymph node that is swollen. These are very important for early diagnosis and treatment. Okay, so what are everything that you have to look for, you can see here, right? Point number L, mammogram. It is used to reveal a cancerous mass. FNAC is a fine needle aspiration cytology. It is used for diagnosis of lesions of the breast. You take out some cells from the fluid that accumulates in the breast. Retracted nipple is a sign of tumor if it is of recent occurrence, right? So this is what is shown to you is a mammogram. Mammogram is shown to you, right? This is how a mammogram is done. Then this is FNAC, fine needle aspiration cytology, and small needle is passed and some area for the biopsy is taken out. Size of the mammary gland is increased by putting an implant. You might have heard of breast implants. So these are basically silicone implants that are put in the breast to show a larger appearance. So these are subglandular implants, right? And the size of mammary gland, it can be reduced by breast reduction surgery. So breast reduction surgery, you are generally removing some part of the breast. Cancer of the mammary gland, it is most common cancer in the females of all ages, and it is more frequent in postmenopausal females due to lack of estrogen. Mastectomy is the surgical removal of one or both breasts and is usually carried out to treat breast cancer. So you might know who this is. Who is this? Angelina Jolie. So Angelina Jolie underwent complete mastectomy, right? And that was done because she had a family history of breast cancer. So to avoid the risk of breast cancer, Angelina Jolie underwent mastectomy, right? Okay. The next is lumpectomy. It is a removal of only the tumor. It is removal of only tumor, that is known as lumpectomy. Radical mastectomy is you remove the breast, you remove the pectoral muscles, and you remove the axillary group of lymph nodes. Okay, then there is something known as modified radical mastectomy, MRM, modified radical mastectomy, where you remove the breast, you remove the lymph nodes, you remove the axillary group of lymph nodes, but you spare the pectoral muscles. You spare the pectoral muscles. All right. Something known as witch's milk in newborns, which is there secreted in both males and females in the fetus. Why is that? Because the maternal and placental hormones, they can cross the placenta. So in a 1 week old child, there are some hormones that are still there, some maternal hormones like oxytocin, etc., which are responsible for secretion of milk in a newborn fetus during the first week of life. All right. So this is known as witch's milk. Then long-standing retracted nipple, it is a congenital anomaly. It is not a sign of breast cancer. Then we talk about male breast carcinoma. Okay, 1 in 100 of all breast carcinomas are seen in males. It has a very poor prognosis. Why? Because females, so if there is a breast cancer in females, there is some fat and glandular tissue in between. So it takes time for the cancer to metastasize. Whereas in case of males, if the cancer is here, it will metastasize very rapidly because intervening tissue is very less. So in males, the breast cancer is having worse prognosis. All right. Now you know about polymastia is supernumerary breast, that is greater than 2 breasts, and polythelia refers to greater than 2 nipples, and they will appear along what is known as the mammary crescent. They are appearing along this line, which is an embryological remnant, a mammary crescent, and then you will have accessory nipples here. That is known as polythelia. That is known as polythelia, right? And gynecomastia, you all know that it is the enlargement or hypertrophy of breast after puberty, and it may be age or drug related. Example, there is some drug known as diethylstilbestrol. It is a cancerous drug and it is used for chemotherapy, right? So this is gynecomastia. Then MRM is modified radical mastectomy, and here you take care to preserve the pectoralis, serratus anterior, and latissimus dorsi. So you spare the pectoral muscles, but you take out the breast and axillary group of lymph nodes, right? Okay. So that was a rapid revision of question number 2. That was a rapid revision of question number 2. This was otherwise almost 1 hour, 1.5 hour lecture on my Unacademy page, and I have tried to cover it in 15 minutes. Very quickly I have gone through it. Okay? If there's any point that you don't understand, you can go and watch that lecture on Unacademy, right? But were you guys able to understand at least the main points that I explained, the main points that I stressed on? Will you be able to write at least 10 to 15 points of the clinical anatomy of the breast? Yes or no? Okay, very great, very great, very great. सबको आ गया समझ? Yes, Tejasvi, you will get the notes for this class. Okay? You will get the notes on my Telegram channel, that is @Unacademy, NEET PG Chetanya. Alright, you can join this Telegram channel. You know how to join a Telegram channel? You will get the notes there. Okay, great. So just download Telegram and join this Telegram channel. Just search it in the Telegram search box. Alright. Then we talk about serratus anterior. Alright. There are 8 digitations of the serratus anterior. So first I'll show you an image of the serratus anterior. So have a look at how the serratus anterior looks like. So there are 8 digitations. Can you make out 1, 2, 3, 4, 5, 6, 7, 8. कुछ गड़बड़ होगी ना? Yeah, basically 8 to 9 digitations. So they've shown an abnormality where there are 9 digitations. Generally, we say there are 8 digitations. There are 8 digitations coming from the upper 8 ribs. Alright. So if you look here, there are 8 digitations from the upper 8 ribs in the mid axillary line and from the fascia that covers the intercostal space. The first digitation, it appears in the posterior triangle of the neck. Just leave this point for now. It comes from the outer border of the first rib and from an impression on the second rib, from a rough impression on the second rib. So that's how the first digitation is coming. The 5th to 8th digitation, they will interdigitate with the costal origin of external oblique. Okay? Origin of serratus anterior is important. And where are they inserting? On the medial border of the scapula. So now you understand how they are going. If this is the ribs, they are going from the ribs and they are going in front of the scapula on the costal surface of the scapula. They will go to the costal surface of the scapula. All the 8 digitations, they will pass backward around the chest wall and they are inserted into the costal surface of the scapula along its medial border. Right? The first digitation, it is inserted from the superior angle to the root of the spine. The second and third digitations, they are inserted on the medial border, and the 4th to 8th digitations are inserted in a area over the inferior angle. So see, if you look at the back of the scapula, see, this is the scapula, this is the spine of the scapula that you can see. The first digitation is present above. The second and third digitations, they are attached on the medial border, and the 4th to 8th digitations, they are attached on the inferior angle. Okay, on the costal surface. So from here you're able only to see the back. They are attached on the front side, right? And then what about the nerve supply? C5, C6, C7 give the roots of the brachial plexus. They give the long thoracic nerve. The roots of the brachial plexus, they will give the long thoracic nerve, and this long thoracic nerve, it will supply the serratus anterior. It enters through the apex of the axilla behind the first part of the axillary artery, and then it reaches the medial wall of the axilla to lie on the surface of the muscle. So C5, it supplies the first and second digits, C6 supplies the third and fourth digits, and C7, it will supply the fifth to eighth digits, right? So if I ask you, so this question, if it is to be asked in a clinical anatomy perspective, right? So how are questions in the next examination going to be asked? So if I ask you a question, if I damage, okay, the C6 root of long thoracic nerve, which digitation is affected? Which digitation is affected? So now this is kind of a clinical anatomy question, right? So your options can be, option A is 1, option B is first digitation, option B is third digitation, option C is fifth digitation, option D is seventh digitation. Choose your answer. 1, 3, 5, 7. So what is your answer? Quickly, guys. Very simple question. Right. So third and fourth digitation. So the answer will be option. What will be the answer? Option B, right? The third digitation, because fourth is not here in the options. So the third and fourth digitation are the ones that are going to be affected in this case. Okay, so similarly, you can see here the complete nerve supply. So sometimes they may ask you about the nerve supply of serratus anterior. There's generally a question in your examination that says that write down the nerve supply of. Okay, they will give you a question, write down the nerve supply of, and then they will give you, let's say, 5 muscles. They will give you 5 muscles, A, B, C, D, E. One of them is going to be serratus anterior, and you will write down long thoracic nerve, and you will write about each individual digitation also. Then you will get complete marks. There is no scope for anyone cutting any marks here, right? Then we talk about what are the actions of the serratus anterior. So how I remember the actions of the serratus anterior are that it is the boxer's muscle. It is the boxer's muscle. So when you do this action, in this action, you are involving your serratus anterior. It is the boxer's muscle. Okay, right? You get this action. This is the boxing action. So this is a boxer's muscle. This is a boxer's muscle. So what it is doing, just imagine that you are actually carrying out boxing. You are actually carrying out boxing. Okay. So what in this action, what are you doing? You are protracting the upper limb or retracting it. This is retraction. This is protraction. So you are pulling the scapula forward around the chest wall. Along with the pectoralis major, it will pull the scapula forward around the chest wall and it will protract the upper limb. Alright. So in the punching action as well as the pushing action. Okay. When do you carry out the pushing action? When do you carry out the pushing action? Alright. So I have a picture here. So see this man, when he is pushing this wall, this is a wall, right? So when he is applying force here on this wall, that is also a pushing action, and that will again require serratus anterior. That will again require serratus anterior, right? So that is how you will see these are the functions of serratus anterior. And right, so the fibers are, this is the main action, right? So you will write, you will not ever forget to write boxer's muscle, pushing and punching action, pushing and punching action. Besides that, the fibers are inserted on the inferior angle. Fibers, they are inserted onto the inferior angle. So fibers are inserted on the inferior angle, so they will pull it forward and they will rotate the scapula to turn the glenoid cavity upwards. They will pull it forward. Okay, give me a second, guys. Anyways, what am I saying? This is the first point. The second point is that the fibers that are inserted onto the inferior angle of the scapula, right? So this is the glenoid cavity, this is the inferior angle of the scapula, right? So the fibers that are inserted on the inferior angle of the scapula, they will pull it forward and they will they will pull this forward and they will rotate the glenoid cavity upwards. They will rotate it upwards. And since it rotates upwards, so you can help the trapezius in overhead abduction. So serratus anterior helps in overhead abduction by turning the glenoid cavity upwards. So earlier the glenoid cavity, it is in a horizontal position. When the serratus anterior pulls on the inferior angle, that will turn the glenoid cavity upward, and that will help in overhead abduction. So which are the two muscles involved in overhead abduction? Overhead abduction is abduction between 90 degree, greater than 90 degree, and that is carried out by two muscles, trapezius and serratus anterior, with the help of serratus anterior. Okay, so you know the angles of abduction. Do you know about the angles of abduction? Abduction, if it is in 0 degrees to 15 degrees, it is carried out by supraspinatus. In 15 to degrees to 90 degrees, it is carried out by deltoid, and greater than 90 degree, it is carried out by trapezius and serratus anterior. Is clear to you? So if you are asked about muscles involved in abduction of the upper limb, this is what you have to write. Okay. Then what else does the serratus anterior do? It will steady the scapula and it will help in forced inspiration, right? So these are the four functions that you can write for serratus anterior. Steadies the scapula during weight carrying, okay, and helps in forced inspiration. These two functions you should never forget. Pushing and punching action like a boxer muscle and overhead abduction. These two functions, please do always remember to write these. ठीक है, ये तो थोड़े accessory functions हैं. Here, third question is done. Can we move to the fourth question? It is again regarding the serratus anterior. Fourth question is regarding the winging of the scapula. It is regarding the winging of the scapula and the clinical testing of serratus anterior. So if there is a paralysis of the serratus anterior, there is going to be winging of scapula. What is there in winging of scapula? See, this is the inferior angle of the scapula. This is what you see here is the inferior angle of the scapula. And what you see here, this is the medial border of the scapula. Now compare the scapula of right side with that of the left side. Okay. The right side, it is unduly prominent. It is much more prominent than it should be, right? So, okay. So since it is so prominent, that is because of paralysis of serratus anterior, and this phenomena is known as winging of scapula. Okay. So unduly prominent inferior angle and medial order, and the person is unable to carry out which actions that are performed by serratus anterior. So what does serratus anterior do? It does pushing and punching actions. So person is unable to push. Okay, so when he tries to push this wall, this hand feels weakness and he is not able to apply force using this particular serratus anterior. All right, so his pushing and punching action is weak and he is unable to carry out overhead abduction. All right, and if he tries to do that, if he tries to push the wall, then his winging of scapula becomes even more prominent. It depends on how much paralysis is there. Okay, for clinical testing, you will apply forward pressure with hands against a wall or against an external resistance, and that will make the medial border and inferior angle prominent. So this is the clinical testing of winging of scapula. Clinical testing for winging of scapula. So when will there be winging of scapula? When will there will be a paralysis of serratus anterior? So which nerve will be involved in such a paralysis? Question: which nerve will be involved in winging of scapula? Okay. So if I have to make the question an image-based question, I'll give you a image of a person who has a winged scapula and I will ask this question. Okay. Okay, you all are correct. The answer is long thoracic nerve. Root value. What is the root value? C5 to C7. It is also called as the nerve of Bell. It is also called as the nerve of Bell. Okay. Yes, it is possible to injure this nerve during a mastectomy. Right. So see, this is the how a clinical anatomy question and an image-based question can be asked together. So question: which nerve of the patient is injured? Okay, so this image will be given to you and it will be asked that which nerve is injured. Which nerve is that's how a question can be framed here. Right? So should we move to question number 5? Brachial plexus. This should be very easy. You must have studied this at least 100 times. Brachial plexus, I'm sure you all have already read, but I'll tell you the important points very quickly and we'll move ahead. So ठीक है, इधर से पढ़ाऊं, उधर से पढ़ाते हैं. Look here. You clear up till the first 4 questions? Any doubt in the first 4 questions? We want an embryo session, right? We can have an embryo session as well. That's great. So Sangeet, this is what I want. I want you guys to tell me कि मैं क्या session लूँ, right? नहीं तो मैं अपने according लेता रहूँगा. But then I want all the sessions to be the sessions which are of topics which are the ones that you find difficult to do. Okay? Okay. So now you've told me we'll do an embryo session. So somebody asked for a basics of ECG session on my Telegram channel. So today evening, I'll try to do a session on basics of ECG, where I'll mainly be talking to you about the limb leads. I'll talk to you about the limb leads. I'll talk you through some of the basics of the ECG, right? Again, obviously not the medicine portion, but the physiology portion, Okay, that we will do today. So I come here. So first of all, when you talk about the brachial plexus, what you have to know is that brachial plexus, it has 5 parts. It has roots, then it has trunks, all right. It has How many roots? Roots are C5 to T1. Then it has 3 trunks. Then these 3 trunks all divide into a ventral and dorsal division, which will form 3 cords, and they will ultimately give a few branches, right? So there are branches that arise directly from the roots. Then there are branches that arise from the upper trunk. There are branches that arise from cords. Okay, so there are branches from the roots, there are branches from the trunks, and there are branches from the cords. Okay, divisions, they do not give any branches. Okay, so branches from the roots, please remember, there are 2 main branches from the roots. There are actually 3. The first branch from the roots is the dorsal scapular nerve, which will supply the muscles on the border of the scapula, the levator scapulae muscle, the rhomboid minor, and the rhomboid major. It will supply these 3 muscles. Okay, the long thoracic nerve, it will supply the muscle on the medial border of the costal surface of the scapula, that is the serratus anterior. So dorsal scapular, long thoracic, and the third nerve that is arising from the roots is the phrenic nerve, mainly from C4. Phrenic nerve arises mainly from C4. Okay, so these are the nerves that arise from the roots of the brachial plexus. Okay, then branches which arise from the upper trunk of the brachial plexus, you have to write mainly 2: suprascapular nerve, and nerve to subclavius. There's also the nerve to longus colli. Okay, I've not mentioned it because in MBBS you generally do not talk about the muscles of the back. Okay, we generally ignore the back. Okay, you will finish your first prof and you will realize that back kabhi kisi ne padhaya hi nahi. Okay, so that is why I am not discussing longus colli, but the nerve to longus colli, it is also a branch from the roots. I've written it here in my notes. You can read it later if you want. Okay, I've also written the root values here. Okay, so I was talking about the branches from the upper trunk. There are only 2 branches which arise from the upper trunk. One is the suprascapular nerve, which supplies the supraspinatus and the infraspinatus. It supplies supraspinatus and infraspinatus. So clinical anatomy question here again for you all. Question on clinical anatomy. If there is a damage to suprascapular nerve, so if there is a damage to initiation of abduction, which nerve is paralyzed? If there is a damage to the initiation of abduction, which nerve is paralyzed? Okay, so for the initiation of abduction, it means the 0 degrees to 15 degrees of abduction, the initial 15 degrees of abduction, that is carried out by the supraspinatus muscle. And now you know that the supraspinatus muscle, it is supplied by the suprascapular nerve. So since it is supplied by the suprascapular nerve, so you will not be able to do this abduction. So what does such a patient do when he has to abduct his arm? See here, the patient will take the support of gravity. The patient will bend down, and when the patient bends down, gravity will carry out the initial abduction, and then the deltoid will take over and help in the rest of the abduction. So if the supraspinatus is damaged, the patient will use gravity for the initial part of abduction. The patient will bend towards that side, and then the arm will automatically get abducted without the role of supraspinatus. So he will bend towards one side for abducting his arm, right? Then supraspinatus and infraspinatus is done. Then there is a nerve to subclavius, which sometimes gives the accessory phrenic nerve. Then branches from the cords. Then you have cords which are formed. There are 3 cords in relations to the second part of the axillary artery. There are 3 cords that are there. Okay, the lateral cord, the posterior cord, the medial cord, and the posterior and the medial cord. The lateral cord, the mnemonic is LML. The mnemonic for posterior cord is either lunar, ulnar, or you can also use stars. And the mnemonic for medial cord is M4U. Alright. Lateral cord, you can see the branches here. L stands for lateral root of median nerve. M stands for musculocutaneous nerve, which continues as the lateral cutaneous nerve of the forearm. And the last L, it stands for the lateral pectoral nerve, which pierces clavipectoral fascia and pectoralis major. All right. The posterior cord, it has 5 branches: U, L, N, A, R, ulnar. All right, but ulnar nerve is not a branch of the posterior cord. Ulnar nerve is a branch of the medial cord. But the mnemonic here is ulnar, U, L, N, A, R. U stands for upper subscapular nerve, which supplies subscapularis. Lower subscapular nerve, which supplies subscapularis and teres major. Then you have nerve to latissimus dorsi, axillary nerve, and radial nerve. The nerve to latissimus dorsi, it is also known as the thoracodorsal nerve. The axillary nerve, it supplies deltoid and teres minor. So teres major, it is supplied by lower subscapular nerve, and teres minor, it is supplied by axillary nerve. Please remember these points. Again, I will write these down separately also. Teres major is supplied by lower subscapular nerve, and teres minor, it is supplied by axillary nerve. Is this very clear? Is this very clear? एकदम मतलब completely clear हो जाना चाहिए. Okay, so we're done with posterior cord branches. I've told you the medial cord branches. M is medial root of median nerve. Then M is medial pectoral nerve. This M is medial cutaneous nerve of arm. This M is medial cutaneous nerve of forearm. And this U is ulnar nerve, right? So M for U, very easy to remember. Medial root of median nerve, medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. Okay, so just draw this diagram in your exam. You will draw the roots. There are 5 roots. Then C5, C6, they will merge to form the upper trunk. C7 continues as the middle trunk. C8, T1, they will form the lower trunk. Then it will give ventral and dorsal branches. This will give ventral and dorsal. This will give dorsal and ventral. All the dorsal branches, they will combine to form the posterior cord. Okay. Then C8 and T1, they will continue here and they will form the medial cord, and from the lateral cord, it will come here from the ventral branches of the upper and the middle trunk. Alright. The ventral trunk of the lower will go as the medial cord. In the lateral cord, it will give the LML branches. The posterior cord will give the ulnar branches, and the medial cord will give the M4U branches. So it's very simple to depict it, especially schematically. Very simple to draw. Draw a schematic diagram. Draw a schematic diagram, and you will be able to do it very well. Yeah, you can write about prefixed plexus. You can write about postfixed plexus during the formation, and you will be able to write about the branches. So brachial plexus should be on your fingertips. Brachial plexus should be on your fingertips. There should be no confusion anywhere regarding the brachial plexus. Okay. So we've covered almost 5 questions. We've covered 5 questions. Is there any doubt so far? Okay. So if you don't understand the brachial plexus, I have a recommendation for you. There is a lecture on nerves of upper limb that I've taken. There's a lecture on nerves of upper limb. There's also a lecture on vessels of upper limb. So upper limb is all about the nerves and vessels that pass through it. Okay. Lower limb, it is more about the compartments. The upper limb is about the nerves and vessels. So if you just watch these 2 lectures, I'll put the links in the chat right now. Give me a second. Okay, so I've put the link in the description. I've discussed in detail the nerves of the upper limb, where I've discussed the brachial plexus, the radial nerve, the median nerve, the ulnar nerve, and all their injuries, the Erb's palsy, Klumpke's palsy, everything, right? So I've discussed, yes, we'll come to the injuries of the brachial plexus. The next question, Rajapavan, you will be surprised, is the injuries of the brachial plexus. The next question is about injuries of the brachial plexus. Don't worry. I've got everything covered. Nothing will be left remaining. Don't worry about that. Okay. So this lecture on the nerves of upper limb, and I will also send you the lecture on arteries of the upper limb. Okay, one of this is a YouTube lecture and the other is a class on Unacademy. Clear? if you want to know more about the brachial plexus. But don't worry, I've taken the useful slides from that lecture and I've put those here. Okay, so these slides are from my lecture only, and I've covered everything for you in a very quick summary. So there's nothing that you will have to do once you go through these notes. There's nothing you'll have to do. Okay, we're done with 6 questions. Do you guys want to break? We'll do a 2-minute break. Okay, so um, Sangeet is asking about upper limb joints. So let me tell you, upper limb, there are two important, मतलब कितने joints हैं? Okay, there is one joint that is very important, and that is the first carpometacarpal joint. Okay, that I will cover in today's lecture. I have not taken a separate lecture on joints of the upper limb. So I'll cover the first carpometacarpal joint today itself, and I will also be covering the elbow joint. Okay, then I will cover the main points related to the shoulder joint, some main points related to the shoulder joint, and some main points related to the wrist joint. Basically, the articulating surfaces that I will cover. Okay. Besides that, there isn't much that you need to do. You have to just know which type of joint is what. You have to know which type of joint is what. Okay. So let's start with injuries of the brachial plexus. Let's start with injuries of the brachial plexus. Just allow me to drink some water. Okay, so we have done 5 questions. We have done 5 questions, 5 theoretical questions, and we've done them in 1 hour. So we are at a good speed. We are doing one question in 12 minutes. That's faster than I expected. Done very long questions so far. So are you guys feeling like you are revising something and you're feeling that you are learning something new and you're getting a confidence that you will be able to write those answers in the question paper? Is the purpose of the class being accomplished? Do you think you are feeling that you are getting some confidence? Would you share this class with your friends, with your classmates? Okay, great. Right. Thank you so much, every one of you. So let's start with brachial plexus injuries. Let's start with brachial plexus injuries. So which is the most severe type of upper limb paralysis? What according to you will be the most severe type of upper limb paralysis? The most severe paralysis will be when there is complete paralysis of the brachial plexus. So what is the meaning of global? Global means complete, around the globe, 100% global, total brachial plexus birth baby, right? So this is the most severe type of paralysis. The child is born without a brachial plexus or with a completely paralyzed brachial plexus, and this is the most severe type of paralysis, right? This is the first thing that you will write when you talk about brachial plexus injuries. This is the first brachial plexus injury that you will write, the global total brachial plexus birth baby. Okay. Then when we talk about the second and third, these are more important. These are slightly more important. We'll talk about the Klumpke's paralysis and we'll talk about the Erb's paralysis. Erb's is known as upper trunk paralysis and Klumpke's is known as lower trunk paralysis. Remember, brachial plexus has roots, trunks, cords, divisions, and branches. So here, upper trunk, there are three trunks, right? Upper, middle, and lower. So if the upper trunk is affected, that is Erb's palsy. If the lower trunk is affected, that is Klumpke's paralysis. That's the first basic concept that you have to remember. Upper trunk paralysis is Erb's, E for Erb's, upper trunk. Klumpke's is lower trunk. That will simplify everything for you. Once you know upper trunk and once you know lower trunk, everything else will be a piece of cake. Everything else is a piece of cake. Okay. See here. There is something known as Erb's point. There is something known as Erb's point, and the injury of this Erb's point is known as upper Erb's palsy, basically. Okay. What is Erb's point? And first, let's see in which all scenarios can Erb's point be injured. It can be injured in birth injuries, on falls on shoulders, and anesthesia. Okay. These are the three possibilities in which you can have Erb's palsy, and it will mainly affect the C5 and C6 roots. Again, mainly C5, partly C6. So what is the root value of injury in Erb's palsy? Okay, remember the root value for upper trunk. The root value for upper trunk. What was the root value of the upper trunk? Upper trunk root value was C5, C6. Upper trunk root value was C5, C6. So these are the injured trunks in the, these are the injured root values in the brachial plexus. Understand? Upper trunk, C5, C6, these are the injured root values in the brachial plexus. Now, C5, C6, you have two major nerves that are going to be there. The axillary nerve and the musculocutaneous nerve. Okay. The suprascapular nerve and the nerve to subclavius also arises here, right? That's true. So how is this, why is this called as the Erb's point? I'll tell you first a little bit about the Erb's point. Okay. So there is one nerve coming from here. There is one nerve coming from here. Then there is one trunk that is being formed here. There are two nerves going here. And right. So this is known as Erb's point. This is known as Erb's point. Why this is being known as Erb's point? Because this is the confluence site, or this is the common point related to 6 nerves. This is related to 6 nerves. What are the 6 nerves that meet here? Right? First of all, this is a point in the upper trunk. This is a point in the upper trunk. So what will be the root values that will be coming from here? C5 and C6. Then there are two nerves that are given here. What are the nerves that are given here? Suprascapular nerve and nerve to subclavius. Nerve to subclavius. And then the upper trunk, it divides into two divisions. So it divides into the ventral and dorsal divisions. So these are the 6 nerves that are there at the meeting point. That is known as Erb's point, and that is why this is known as Erb's palsy. So these are the 6 nerves: C5, C6, suprascapular, nerve to subclavius, ventral division of upper trunk, dorsal division of upper trunk. So that is how Erb's point is a confluence point of 6 nerves, 6 particular nerves. Okay. So you will think about 2 nerves which have their root values located in C5, C6. C5, C6 are related. There are 2 nerves. One is the axillary nerve that is relevant here. The other is the musculocutaneous nerve. Okay. So the axillary nerve, it supplies 2 muscles. I told you, deltoid and teres minor. Okay. Deltoid and teres minor. The main muscle that we will focus here is the deltoid. Okay. So if the axillary nerve is damaged, there is damage to deltoid, and if there is damage to deltoid, there will be loss of abduction. I told you deltoid takes part in the main abduction, that is 15 to 90 degree, and deltoid is a lateral rotator of the arm. Deltoid is a lateral rotator of the arm. It rotates the arm laterally. So there will be loss of lateral rotation of the arm, loss of abduction, loss of lateral rotation. So what will happen? There is no abduction. So the arm is adducted. It is joined along the body. and there is no lateral rotation, there is medial rotation. So the arm is rotated medially like this. So what will happen? There is medial rotation. So this will lead to policeman or waiter's tip hand. Policeman or waiter's tip hand. So whenever a policeman takes a tip, he is going to take it very cleverly from behind. So he is going to make his hand in a very clever position. So this is known as a policeman or a waiter's tip hand. Okay. And what happens, because the musculocutaneous nerve is damaged, the biceps and the brachialis are damaged. So there is loss of flexion of forearm, there is loss of supination of forearm. So the forearm will remain in a pronated and a straight position. So the biceps and supinator jerks are also lost, and you lose sensation over skin of deltoid. This is all the damage that will take place. So you can see that the infant, this should be shown adducted. There should be adduction that should be shown here. But just have a look at his arm. Have a look at his arm. It looks like he is trying to take a tip from behind. You know what is a tip? Or policeman takes a bribe. So he is taking it in a very clever way. कि थोड़ा सा पीछे से थोड़ी सी रिश्वत दे दो, ठीक है, something like that. So that is what a policeman or a waiter's tip hand is going to be, right? Policeman. Okay, thank you for the praise on the handwriting, but I'm very sure it's a sarcastic comment. Okay, so that's the thing here. So I hope you understand what Erb's palsy is now. What is Erb's palsy? Clear? Next, let's move to Klumpke's paralysis. Let's move to Klumpke's paralysis. Okay. ये तो तुम मेरे मजे लेने लग गए. It is legible, I think, at least, है ना? समझ तो आ रही होगी. Handwriting इतनी भी बुरी तो नहीं है. Right. So Klumpke's paralysis, you will have damage of the lower trunk. You will have damage to the lower trunk. Lower trunk, the root value is C8 T1, and this may be mainly T1. Mainly T1 is going to be affected. There mainly C5 was going to be affected. Here mainly T1 is going to be affected. So Klumpke's paralysis, like I told you, is lower tongue palsy. So what is happening when does this happen? When you clutch something very tightly after falling from a height. So there will be undue separation. There will be undue separation. For example, you can see this person. He was falling from a height and he held this branch. So because of that, there is lot of stress here on the lower trunk. So that is why you will have Klumpke's paralysis. Or it can be also due to a birth injury. It can also be due to a birth injury. And the main feature that is there is claw hand. There are two main features, claw hand and Horner's syndrome in case of Klumpke's paralysis. Because there is damage to the T1 fibers and C8 fibers, there is claw hand. Why? Because they are part of the ulnar nerve. They are part of the ulnar nerve, and they will supply the intrinsic muscles of the hand and the ulnar flexors of the wrist and the finger. So you will have claw hand, which is hyperextension at metacarpophalangeal joints and flexion at interphalangeal joints. Flexion at interphalangeal joints. So this is what is claw hand. You will have hyperextension at these joints and hyperflexion at these joints. You will have hyperflexion at these joints. This is known as ulnar claw hand. Alright. Okay. And you will have hyperextension at MCP joints, flexion at IP joints, and you will have damage to intrinsic muscles of the hand. Okay, because the hand is supplied mainly by the C8 T1. The hand is supplied mainly by root values C8 T1. So you will have complete claw hand here. So you will not just have ulnar claw hand, you will also have claw hand of all the fingers. Then you will have some cutaneous anesthesia in the ulnar border, along the ulnar border. Then you will have Horner syndrome. Why? Because fibers of the T1 they are being damaged. Fibers of the T1 they are being damaged, and they give sympathetic nerve fibers to the levator palpebrae superioris. So if those fibers they don't go to the eyelid will drop, and there will be Horner syndrome. Okay, that is one part. Other sweating and everything, all of the features of the Horner syndrome, they're also seen because of damage to T1, which carries sympathetic fibers from the superior cervical ganglion. Then there are vasomotor changes, including arteriolar dilation and trophic changes due to long-standing paralysis. So whenever you mention any damage, don't forget to write about vasomotor changes and trophic changes. So whenever you write any injury in case of anatomy, ideally, whenever you write any nerve injury, you will write about paralysis. You will write about which muscle is paralyzed, which action is lost. Then you will write about sensory loss. Okay, you will write about sensory loss. Then you will write vasomotor changes, and you will write trophic changes. You will write about trophic changes. Okay, so these are the four categories that you should make whenever you describe an injury. All right, so when we described Klumpke's paralysis, we told about paralysis, we told about sensory loss, we said vasomotor changes, and we told about trophic changes. So that is how you have to write an anatomy answer. Okay, so should we move to question number 7? Should we move to question number 7? Do you have any doubt in Erb's or Klumpke's paralysis? I hope you won't forget which one is Erb's, which one is Klumpke's. Upper trunk paralysis, Erb's paralysis, policeman tip hand. Klumpke's paralysis, lower trunk paralysis, complete claw hand. Please remember these two things. Yeah, इतना ही याद रखना, कुछ बहुत ज्यादा नहीं याद रखना. That will help you write down the complete answer. Ulnar, ulnar कह रहा हूँ. Erb's, Klumpke. क्या करना है? Upper trunk, lower trunk. C5, C6, C8, T1. This will have policeman, tip hand. This will have Klumpke's will have claw hand, complete claw hand. Okay, so that's all that you have to remember here. When you remember the differentiation between Erb's and Klumpke's, you will be able to form your answer around these basic points. Okay, is everything clear? Should we move ahead? Okay. Allow me to get some water. I'll be back in 1 minute. Meanwhile, have a look at the relations of the axillary artery. Just have a look at the relations of the second part of the axillary artery. Just try and understand these. I'll be back in a minute. Okay. So let's start here with the axillary artery, the relations and the branches. So again, this has been covered also in my class on arteries of upper limb. You go and watch my class on arteries of upper limb, you'll realize that I have already covered this as well. But right now, let's begin with the axillary artery, the relations and the branches and everything. So right now, see here, have a look here. This is the axillary artery that is running. So where does the subclavian artery become the axillary artery? Where does the subclavian artery become the axillary artery? So at the outer border of the first rib, at the outer border of the first rib is where you will say that the axillary artery begins. Okay, that is where I say that this is where the subclavian artery ends and this is where the axillary artery starts. And it goes up till the lower border of the teres major, lower border of the teres major, after which it becomes the brachial artery. After it becomes the brachial artery. So now it is divided into three parts by a muscle. It is divided into three parts by a muscle that is known as pectoralis minor muscle. So the P minor muscle, it is going to divide the axillary artery into three parts. Now, if it is divided into three parts, there must be some branches that are there of each part. The easiest way to remember the branches of axillary artery are by remembering 1, 2, 3. That is, the first part it gives one branch, the second part it gives two branches, the third part it gives three branches. So what are the important things that I've told you so far? The boundaries of the axillary artery, now the extent of the axillary artery, the muscle that divides it into three parts, and now I'm going to tell you the branches. The first part it gives one branch, second part gives two branches, third part gives three branches. First part, the branch is called as superior thoracic artery. Superior thoracic artery. Second part, very simple. There is a lateral thoracic artery and there is a thoracoacromial artery. There is a lateral thoracic artery and a thoracoacromial artery. The third part, again very simple, anterior circumflex humeral artery, posterior circumflex humeral artery, and the largest artery, the largest branch, the subscapular artery. The subscapular artery then further gives few branches like circumflex scapular artery and thoracodorsal artery. Yeah, so I'll just show you this in the diagram as well. So look here. Above the pectoralis minor, this is the first part. This is the first part of the axillary artery. From the first part of the axillary artery, the branch that arises is the superior thoracic artery. This is the superior thoracic artery. Then this is the second part which is under the P minor, which is under the cover of P minor. The first branch that arises here is the thoracoacromial artery. The first branch that arises here is the thoracoacromial artery, and the branch that runs along the P minor is the lateral thoracic artery. It is the lateral thoracic artery. The thoracoacromial branch, it divides into four. It divides into four. It pierces the clavipectoral fascia and it will give four branches. A, P, C, D. Okay. Acromial branch, pectoral branch, clavicular branch, and deltoid branch, right? So it gives four branches A, P, C, D, right? Not A, B, C, D, but A, P, C, D, right? Then the third part, it is after the P minor and it gives the anterior circumflex humeral and the posterior circumflex humeral, which wind around the neck of the humerus. They wind around the neck of the humerus. And the largest branch is the subscapular artery, which gives a circumflex scapular artery here, and it gives a artery known as the thoracodorsal artery, which supplies the muscle known as latissimus dorsi, right? So now, are we clear about the branches of the axillary artery? Are we clear about the course and the branches of the axillary artery? We'll have a look at the relations, but first, more important, you should know the branches of the axillary artery. First part, second part, third part separately. Okay, this much is clear. Okay. When I talk about the relations of the axillary artery, there are relations of the first part, there are relations of the second part, and then there are relations of the third part. Okay. So I don't want you to remember the relations of the first part. I don't want you to remember the relations of the third part. I want you to focus on the relations of the second part. Why are they important? Because the brachial plexus, it is related to the second part of the axillary artery. See, the anterior relation of the second part of the axillary artery, you know, the pectoralis minor, it will be lying above the second part of the axillary artery. So the anterior relation is the pectoralis minor. Then what is the posterior relation going to be? Posterior chord of brachial plexus. Medial relation is medial chord of brachial plexus. Lateral relation is lateral chord of brachial plexus. Okay, so you know these four relations very clearly. Then what else you have to remember here is that axillary vein, it runs medial to the axillary artery. Okay, whether it be the first part, the second part, or the third part, axillary vein always lies medial to the axillary artery. Axillary vein always lies medial to the axillary artery. Always axillary vein lies medial to the axillary artery. Then subscapularis, it is the posterior border of the axilla. It is the posterior boundary of the axilla. So it will be here in the posterior boundary of the second part of the, which is the posterior relation of the second part of the axillary artery. So it is easy to remember the relations of the second part of the axillary artery, and these are the ones that are most important. You can also go through the relations of the first part and the third part. That is up to you. Okay, I'm leaving that up to you. But second part, you should be knowing these relations by heart. Second part, you should know these relations very clearly. Very easy to remember relations actually. And you should also know the relation of the axillary vein to the axillary artery. It's always okay. Okay. Cool. Can we move to the next question? So we've done around 7 questions and it's been 1.5 hours. Let's go ahead with the 8th question. So first we are going to define what is a dermatome, and then we are going to talk about dermatomes of the upper limb. Dermatome is the area of skin that is supplied by one single spinal segment, that is called as dermatome. First, the definition of dermatome, very important. Please remember to write this completely. Area of skin supplied by one spinal segment is called as a dermatome. Okay. Then you have to write here that the cutaneous innervation of the upper limb, it is derived mainly from C5 to T1. It is derived mainly from C5 to T1, partly C3, C4, T2, T3, but mainly it is derived from the same as the brachial plexus. Cutaneous innervation comes from C5 to T1, and it is always supplied by the primary anterior rami. It is never supplied by the posterior primary rami. It is always supplied by the anterior primary rami. This is very important. When we study the dermatomes of the lower limb, there is one exception to this rule. That we will see when we see dermatomes of the lower limb. But for the upper limb, all the dermatomes are supplied by the anterior primary rami. Okay. Is this very clear? Anterior primary rami. And there is some degree of overlap. They are not very distinct dermatomes, and that allows for compensation in case of sensory damage. So these are the points that you start with when you write about a dermatome. You first define it, then you define which are the root values, then you tell about anterior primary rami supplying the dermatomes, and then you write about the varying degree of overlap allowing compensation. Right, then you can mention about what is the pre-axial border and what is the post-axial border. So see here, during embryological development, there was some rotation that was carried out of your limb buds. All right, initially your limb buds were not present like this. They were present like this. All right, even your legs, they were rotated. So there was a pre-axial border and there was a post-axial border. So for your upper limb, there was lateral rotation of the limb bud. So your pre-axial border was from your radius and thumb, and this was your post-axial border. This was the axis. This was the pre-axial border. This was the post-axial border. And there was lateral rotation of the limb bud. Okay. Just give me a second, guys. There was lateral rotation of that limb bud, and because of that, the radius it came laterally, and the ulna and the little finger they came to lie medially. When you talk about the lower limb, there was medial rotation of the lower limb. There was medial rotation of the lower limb. So in that case, the pre-axial borders and the post-axial borders will vary accordingly. Okay. So that is one thing that you have to understand, and that is how you define the pre-axial and the post-axial border. So dermatomes of the upper limb, when you talk about the dermatomes, along the pre-axial border, that is along the radial border, there was dermatomes of C3 to C6. The middle three digits were C7, and the post-axial border is C8, T1, T2. Very simple to understand. Try and split this like this. Try and understand it like this. Okay. In the unrotated position, this was your upper limb. So this is your pre-axial border, including your thumb. So this was C3, C4, C5, C6. Then middle three fingers, this was C7. Then the ulnar border, that is the post-axial border, this will be C8, T1 and T2. So try to do it like this. C3 to C6, C7, C8, T1, T2. So that is how you will be able to remember the dermatomes very easily. One more thing, as the limb bud, it elongated, it rotated laterally, it gets adducted, and the central dermatome, it gets pulled in such a way that these are represented only in the distal part of the limb. Okay, so जो center में थे वो सारे इधर खिंच के इधर चले गए, and they are buried proximally. They get buried here proximally. So there is a ventral axial line and there is a dorsal axial line, and that will be where these dermatomes they get buried, and that is the place where the dermatomes are very distinct. So I'll just show you these. Okay, have a look here in the dermatomes. Have a look here in the dermatomes, which is the pre-axial border, which is the post-axial border. You can see easily pre-axial border and post-axial border. Okay, what do you want me to repeat, Sangeet? कौन सा part repeat करूं? Please tell me which part I should repeat. एक बार टॉपिक का नाम ले दो, मैं पूरा रिपीट कर देता हूं. रिपीट द प्रीवियस पेज. ठीक है, ये वाला पेज रिपीट करना है. So देखो, basically what I am saying is, what was our expectation? What was our expectation? ठीक है, हमारी एक्सपेक्टेशन ये थी कि ये रहा प्री एक्सियल बॉर्डर, ये रहा पोस्ट एक्सियल बॉर्डर. ठीक है, इस पे लिटिल फिंगर है, बीच में ये रहे तुम्हारे थंब. बचपन में ये था, और बचपन में बहुत सिंपल था कि ये वाला एरिया सप्लाई करेगा C7, ये वाला C3 to C6, और ये वाला एरिया रहेगा पूरा C3 to C6 का, ये वाला एरिया पूरा रहेगा ये T1, T2. Okay, so this was the expectation. This is your thumb, and this was your middle three fingers. Then this was your little finger, and this was your post-axial border. So our expectation was that this part is going to be T7. Then if I divide it like this, the pre-axial border is going to be C3 to C6. The post-axial border is going to be C8 to T2. But this is not the exact distribution in the adult. This is not the exact distribution in the adult, right? So this one is the pre-axial border. This one is the post-axial border. Okay. So initially I told you that your limb was present like this. It was very short and it was present like this. There was a pre-axial and a post-axial border. It was lying like this. It was lying like this. Then it got rotated laterally and your limb got abducted slightly. Okay? Your limb got rotated laterally and abducted slightly. So what happened? And then it started to elongate, and it started to elongate. So because of that, the dermatomes that were present in the center, okay, the central dermatome, it gets pulled in such a way that these are represented only in the distal part of the lip. So वो खिंच के they came towards the distal part and they are buried proximally. They are buried here proximally. यहाँ पे वो दिखाई नहीं देते, वो बीच में चले जाते हैं. ठीक है? Right? Okay. Thank you, Shiv Varmani. Right, and then you have a ventral axial line, you have a dorsal axial line. So you will see what are the ventral and dorsal axial lines here, right? So have a look at the dermatomes here. C3, C4, C5, C6, C7, C8, T1, T2. So the dermatomes are being separated in between the dermatomes of the preaxial and the postaxial borders. They are separated in between by the ventral axial lines where the dermatomes are getting buried. This is the ventral axial line. And then there is a dorsal axial line on posteriorly, right? So this is the C3, C4. Again, you will see T1, C8, C7, C6, C5, C4, C3, and this is the dorsal axial line, right? This is the dorsal. So this is the about the dermatomes of the upper limb. You can see again, this is the ventral view, this is the dorsal view, the left side. Okay. So this is how you will identify the dermatomes. This is a diagram that you'll have to draw if you are asked about the dermatomes. We move to question number 9. We'll talk about the median basilic cephalic cubital vein now. Okay, so we'll talk about the median vein, median cubital vein, we'll talk about the basilic vein, and we'll talk about the cephalic vein, right? Right. So have a look at this diagram. Very simple diagram. Not much to see. You don't even need to see this diagram. We'll draw it on our own. This is your upper limb. Right? So this will be your medial side. So medial side, okay, take a different color. Medial side, it is the ulnar border. The lateral side, this is the radial border. So on both sides, you have a vein running. On this side, you have a vein which is known as the cephalic vein. You have the cephalic vein. On this side, you have a vein known as the basilic vein. At the level of your cubital fossa, which is your cubital fossa, if you pull up your whatever you're wearing, this depression that you see here, in your elbow, right, in the front of your elbow, that is called as the cubital fossa. There you have a crossing, oblique crossing that is known as the median cubital vein. See here in this diagram, there is an oblique crossing here known as the median cubital vein that is oblique towards the basilic vein. There is a crossing that is oblique towards the basilic vein, right? And on its medial side, you have the basilic vein, and on the lateral side, you have the cephalic vein. Okay. On the lateral side, along with that, you have the lateral cutaneous nerve of the forearm. On the medial side, you will also have the medial cutaneous nerve of the forearm running along the basilic vein. So if you are asked which nerve runs along the basilic vein, it is the medial cutaneous nerve of forearm. And which nerve runs along the cephalic vein? The lateral cutaneous nerve of the forearm. The median cubital vein, it is going to connect it. Median cubital vein, it is going to connect it, and it is oblique towards the basilic vein. So do remember what is the direction in which the cubital vein is running. Okay, so that is what the median cubital vein is, and that is the connection between the cephalic and basilic veins. Okay. So now why is which is the site for IV injections? So ठीक है, so you know that the injection is put somewhere in the arm. ठीक है, यहाँ पे कहीं पे injection देते हैं. So do you know in which exact vein do we want to put the IV injection? Is it in the basilic vein? Is it in the cephalic vein, or is it in the median cubital vein, MCV? Which vein do we give the injection in? Any idea? ये तो पता होगा तुम लोगों को. Right, median cubital vein, not medial cubital, median cubital vein, right? So why do we use median cubital vein? So there are multiple reasons why median cubital vein is suitable for intravenous injections. Why median cubital vein is suitable for intravenous injections? So one of the main reasons is that under the median cubital vein lies the brachial artery. Okay, in the, so median cubital vein is located in the roof of the cubital fossa. It is located in the roof of the cubital fossa, whereas brachial artery, it is a content of the cubital fossa. So there is a separation between the brachial artery and the median cubital vein, and it is separated via the bicipital aponeurosis. So if you put an injection, there is in the vein, you don't want it to go into the artery because the artery has very fast flowing blood. So there is an aponeurosis in between that will prevent the injection from going downwards. You will feel that there is something hard that is there underneath, and the injection, you will not put it too deep. All right. So that is one of the reasons that it is separated from the brachial artery by the bicipital aponeurosis. That is one reason. The second reason is that the median cubital vein, it is connected to the deep veins through perforator veins. So see, just understand this concept. I am looking at it from the side. I am looking at the median cubital vein, let's say from the side. This is the angle at which I am looking it from. Okay, यहाँ से देख रहा हूँ. So this is the median cubital vein. All right, there is some blood that is flowing inside it, and there are some deep veins. There are some deep veins in your elbow. Okay, there are some big deep veins. In between them, you have a bicipital aponeurosis. In between them, here you can see there is a bicipital aponeurosis. There is a bicipital aponeurosis. What is important for you guys to remember is that it is connected to these deep veins through perforators which pass through the bicipital aponeurosis. There are some perforators which pass through this bicipital aponeurosis, and they connected to deep veins. Now try to understand it in this way. If there is a vein and if it is freely present inside your loose tissue, so when you try to put something inside it, it will simply move to the side. It will simply move to the side. ठीक है, ऐसे करूंगा वो side हो जाएगी. But if it is fixed below, right? If it is fixed below through these perforators in the bicipital aponeurosis, therefore it will not move as much. So when I try to pass a needle inside it, it will be stationary. It will stay at its place. So that is one of the major reasons that it is very suitable for IV injections. Third reason, it is relatively superficial and you can easily identify it in the cubital fossa. That is one of the third reasons why you use the median cubital vein. So when you are asked this question, you can write 3 reasons why MCV is suitable for IV injections, cardiac catheterizations, or any procedures where you have to insert a needle or a catheter, right? Question number 9 is done. Now we are going to move to question number 10. Hopefully this will be done in another 5 minutes, and then we can move to question 11. Question number 10 is about quadrangular and triangular spaces of the scapular region. Now to remember this, you have a hand figure, right? You have a hand figure that you use to remember it. So now you're looking at it from the front. You're looking at it from the front, or you're looking at it from the behind. You can see it from anywhere. Accordingly, you will change your orientations. So if you're looking at it from, let's say you're looking at it from behind, what will happen is the teres minor, it will be the most posterior muscle, and the most anterior muscle would be the teres major, because it has to go and insert onto the bicipital groove. On the anterior surface. So this is the teres minor and this is the teres major, and in between them you will insert your two fingers. Like this, right? If I show you this from the posterior view, this is how it should look like to you. When you are looking at it from this side, this is how it should look like to you. Okay, this will give you a 3D orientation or 3D understanding of how things are. So this finger, this upper finger, this is the teres minor. This lower finger is the teres major. This is the humerus, and this is the long head of triceps. So see in this diagram, this is what you should see: teres minor, teres major, triceps, and humerus. Okay, so you can see that there is a triangle that is formed here, and there is a quadrangle that is formed here. Okay. There's a quadrangle that is formed here. Okay. So basically, now you can write the boundaries of all the spaces at least. So this triangular space here, this is the upper triangular, and now this is the lower triangular space. This is the lower triangular space. This is the upper triangular space, and that is the quadrangular space. So there are two triangular spaces and one quadrangular space. So now you can easily write the boundaries here. Try to write the boundaries. What are the boundaries of the quadrangular space? Upper boundary is the lower border of teres minor. What is the lateral boundary? The shaft of humerus. What is the lower boundary? What is the inferior boundary? The upper border of teres major. What is the medial boundary? The long head of triceps. The lateral border of the long head of triceps. So that is the boundaries of the quadrangular space. Now similarly, you can write the boundaries of the lower triangular and upper triangular spaces. That's how you can easily write the boundaries. That's your easy way to write the boundaries, is through your finger mnemonic. Okay. Now once you're done with that, you have to write down the structures that pass through this. Okay. So try to understand this, that if this is the humerus, try to imagine this to be the humerus bone. Okay, I'll try to draw this as a bone. This is the humerus bone. So somewhere here you have the neck of the humerus. This is the surgical neck of the humerus. And somewhere here you will have the spiral groove. Somewhere here you will have the spiral or the radial groove. Okay, so now it becomes even more simpler to remember what is the structure passing through which region. Okay. Through the quadrangular space, structures which go to the neck of humerus, they are the ones that are going to pass. So posteriorly, what will go? There will be one artery and one nerve. What is the artery? Posterior circumflex humeral artery, and which is the nerve? Axillary nerve. So two contents of the quadrangular space are posterior circumflex humeral artery and axillary nerve. Now, what is the structure that winds around the spiral groove? The profundi brachii artery and the radial nerve. There is one artery and one nerve. Which is the artery? It is a branch of the brachial artery. It is the profunda brachii artery. So that will pass through this structure, that is the lower triangular space. So that is the profunda brachii artery, and along with that you will take the radial nerve. Along with that you will take the radial nerve. Now which space is left? Only the upper triangular space is left, and from here remember there is something that is hooking here between the origins of the subscapularis, and that nerve is known as the that artery is known as the circumflex scapular artery, okay, which is a branch of the subscapular artery, which is a branch of the third part of the axillary artery. Circumflex scapular artery, it will be hooking around this upper triangular space. Deep brachial artery or profunda brachial artery, right? Try to write that. So now can you write easily the boundaries and the contents of the three spaces? Is it difficult to remember which is the content of which space? Is it difficult to remember that? Is it difficult to remember that? I hope you can easily write down the boundaries and the contents now. कोई difficulty? Boundaries and contents लिखना आसान बना पाया क्या मैं? Was I able to make it easier for you to write down the boundaries and contents? Just imagine the humerus here, that will make everything very simple for you. Will you be able to write this down now? Quadrangular and triangular spaces, boundaries and contents. Can you write this? Okay, no. No, not at all. None. कोई बात नहीं संगीत. Question number 11. ये no not at all will you forget this के लिए था कि हाँ ठीक है. Next, let's move to the applied anatomy of the axillary nerve. Let's talk about axillary nerve damage, applied anatomy of the axillary nerve. So tell me the two muscles. What are the two muscles that are supplied by the axillary nerve? What are the name of the two muscles that are supplied by the axillary nerve? Name two muscles supplied by the axillary nerve. Okay, know about any difficulty, right? Thank you, Sangeet. Deltoid and okay. Tanya Shafe has written deltoid and teres minor. Very good, Tanya. Deltoid हो गया और तुम्हारा हो गया teres minor. ये दो मसल हो गए, बहुत बढ़िया जी. क्या तो ये सप्लाई करता है एक्सिलरी नर्व इन दो मसल्स को. ठीक है, इतनी बात क्लियर है. नॉट teres major. No, not teres major. दीपिका गलती कर रहे हो. Who supplies teres major? What is the nerve supply of teres major? Tell me the nerve supply of teres major. I told you you will forget this. What is the nerve supply of teres major? Absolutely correct. Lower subscapular nerve. The nerve supply of teres major is lower subscapular nerve. That's correct. Okay. So please don't make this mistake, and do hit the like button on this video if I have corrected you, if I have helped you in some way or the other. Thank you for hitting the like button. Okay. So next, let's move to the axillary nerve damage. Let's talk about axillary nerve damage. Okay. Axillary nerve damage is occurring in when there is where does the axillary nerve pass through? I told you it passes through the surgical neck of the humerus along with the posterior circumflex humeral artery. It passes along the neck of the humerus. Okay, surgical neck of the humerus along with posterior circumflex humeral artery. So it is damaged when there is a dislocation of the shoulder or there is a fracture of the surgical neck of the humerus. That is when you will have damage to the axillary nerve, dislocation of the shoulder or fracture of the surgical neck of the humerus. And what are the effects of axillary nerve damage? It will cause rounded contour of the shoulder to be lost. Okay, the deltoid, it gives a very beautiful contour to the shoulder. ठीक है, वो shoulders जो अच्छे से लगते हैं ना, जिनमें ऐसे बड़ा अच्छा सा round सा shape होता है. People who exercise their shoulders, who carry out exercises or go to the gym, they have very beautiful rounded contours of the shoulder. So there's damage to the axillary nerve. Deltoid is gone. And because the deltoid is gone, there is loss of this rounded contour and the shoulder becomes flattened. Shoulder becomes flattened and the greater tubercle becomes prominent because shoulder becomes flattened. Shoulder is flattened. Okay. Second thing, there is paralysis of the deltoid. There is obviously paralysis of the deltoid. So there is loss of power of abduction up to 90 degree. Because I told you that deltoid is responsible for abduction from 15 degree to 90 degree. So there is loss of power of abduction. There is loss of power of abduction. Rounded contour is lost, loss of power of abduction, and there is sensory loss over the lower half of deltoid. And that is known as regimental badge. That is known as regimental badge. Why? So if I draw a person from the side view for you, let's say this is a person who I am drawing on the side view for you. Okay, यहाँ इसे दिखा देता हूँ. Do I have a picture of the deltoid? Look here, this is a person from the side view. This is a picture of the deltoid. So there is some skin over the deltoid and there is damage over this lower region. There is damage over this lower region. And if you look at an army officer, do you know army officers? They wear the badge of their regiments here, right? They wear a badge here. They usually have a star here or some badge here, right? That is the area in which you will have some sensory loss. That is the area of sensory loss. So because that is their red area of this area of sensory loss, so that is known as regimental badge. That is known as regimental badge. Yeah, it is seen in axillary nerve damage. Okay, so you can mention that when you are writing your answers. Let's come back here. Yeah, so that's the end of question number 11. That's the end of question number 11. That's everything that is there about the applied anatomy of the axillary nerve. Question number 12, we are going to talk about the scapular anastomosis, anastomosis around the scapula and clinical significance of scapular anastomosis. Scapular anastomosis and its clinical significance, right? So let's do this. So guys, my plus referral code is Chetanya 10. In case anybody you know is planning to take a plus subscription, you can refer to them my plus referral code. And if you like my lectures, do try and dedicate a hack to me on Unacademy. I would really be glad if you could do that. Almost 2 hours since we've been doing our questions. So we've done about 11 questions. Let's see how much more time it takes. It's a one-shot video. So we'll try to cover as much as we can. So scapular anastomosis, the thing that you have to understand here about the scapular anastomosis and its clinical significance is that scapular anastomosis is a collateral circulation. Okay? So when there is a blockage of the subclavian artery, okay, there must be some way by which the blood should reach the axillary artery. Okay? So you've made an anastomosis between the subclavian artery and the axillary artery, right? And it is between the first part of the subclavian artery and the third part of the axillary artery. So have a look here. Show this to you in a image that I will draw. So this is the subclavian artery. Let's say this is the subclavian artery, and then it continues after the outer border of the first rib as the axillary artery. Okay, subclavian artery is divided into three parts: 1, 2, 3, and axillary artery is again divided into three parts: 1, 2. Okay, carry it. So the anastomosis, it exists between the longest, the parts which are farthest away, right? So this is the first part of subclavian artery, and this is the third part of the axillary artery. So the anastomosis, it should exist between the first and the third part of subclavian artery and third part of axillary artery. So that if there is a damage here, 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 or if there is a damage here, if there is a damage anywhere along this region, there is a collateral circulation that is available. Okay? If the anastomosis was here, then there was very less chance in which it will be effective. But now, since the anastomosis is between the most distant parts of the arteries, okay, therefore the anastomosis will be very effective. The anastomosis will be very effective. So that's the first thing that you have to remember, that it is between the first and the third parts. So now, what you have to write, what are the branches of the third part of the axillary artery? What are the branches of the third part of the axillary artery, and what are the branches of the first part of the subclavian artery? Okay. Yeah. Apsara ji, for your reading, I would recommend that you, especially for your prof examinations, you can refer to two books: student edition of Gray's Anatomy, Student Gray's, and you can refer to P.D. Chaurasia's Anatomy, right? Some students, they refer to Vishram Singh. That's totally up to you. But I would recommend that you do give a reading to Student Gray's. It's especially, even if you don't read it, go through the diagrams. Go through the diagrams, because Student Gray's has some beautiful diagrams. Alright? Now let's come back to what I was saying. Right. So the branches here that you know are for the axillary artery, the third part, it gives branches known as ACHA, PCHA, that is anterior and posterior circumflex humeral arteries, and subscapular artery. Now subscapular artery also gives a branch known as circumflex scapular artery. The first part of subclavian artery, it gives branches that are three branches that are VIT. Okay, vertebral artery, internal thoracic artery, and thyrocervical trunk. Thyrocervical trunk. Okay, thyrocervical trunk. Now, the vertebral and the internal thoracic arteries, they are not relevant to us here. Only the thyrocervical trunk is relevant, and it further has three branches: SIT. SIT. What is S here? S is suprascapular artery. I is inferior thyroid artery, again not relevant, and T is thyrocervical trunk. This is also giving further branches. Sorry, this T is not thyrocervical trunk. Thyrocervical trunk has already come. Sorry. This T is transverse cervical artery. That is going to be relevant to us. T is transverse cervical artery. So have a look here. What are the arteries that will take part in the anastomosis? What are the arteries that will take part in the anastomosis? From the first part of the subclavian artery, you will have thyrocervical, right? You will have thyrocervical. A branch is suprascapular artery. Okay, I told you a branch of thyrocervical trunk is suprascapular artery. The other artery that will take part here is the deep branch of the transverse cervical artery, which is again a branch of the thyrocervical trunk, The third part of the axillary artery, the only relevant artery is the subscapular artery, which gives another branch known as the circumflex scapular artery. So the anastomosis is essentially between the thyrocervical trunk, parts of the thyrocervical trunk, and the subscapular artery. Okay. Then there is some anastomosis over the acromion process also. This is known as the acromion anastomosis, and that is between some branches of the thoracoacromial artery, suprascapular artery, and posterior circumflex humeral artery. Okay, I'll not go into the details of this. I will only talk about the scapular anastomosis. Okay, so have a look at this diagram. This was your thyrocervical trunk coming from the first part of subclavian artery. This thyrocervical trunk, it gives a branch here known as the suprascapular artery, and it gives a branch known as the transverse cervical artery. Transverse cervical artery has a superficial branch and a deep branch, and the deep branch, it also runs around the scapula. Okay, it supplies the scapula and it runs around the scapula. So this is the branches coming from the first part of the subclavian artery. Then you move on to the third part of the axillary artery. From here you had an artery known as the subscapular artery. So subscapular artery, it will anastomose here at the inferior angle with the deep branch of the transverse cervical artery, and it will give a circumflex scapular artery which will anastomose here with the suprascapular artery. So there are two circles that you can see. This is one circle, this is one circle where the circumflex scapular artery anastomoses with the suprascapular artery, and the deep branch of the transverse cervical artery, it will anastomose with the subscapular artery. Okay, I don't know why there is a lag in my pointer. Okay, this is going to anastomose here with the circumflex scapular artery, and this deep branch of transverse cervical artery, it is anastomosing here at the inferior angle with the subscapular. Besides that, I told you that there is an anastomosis over the acromion process. There is an anastomosis over the acromion process, and there you will have a branch from the posterior circumflex humeral artery coming, known as the acromial branch of the posterior circumflex humeral. You will have an acromial branch of the suprascapular artery, and you will also have an acromial branch of the thoracoacromial artery, which is also from the second part of the subclavian artery. These three will anastomose here over the acromion process, and that is known as the acromion anastomosis. That is known as the acromion anastomosis. Okay. So that is what you have to write about the scapular anastomosis. And what is the clinical significance? It provides collateral circulation through which blood can flow when the distal part of subclavian artery or proximal part of axillary artery is blocked. So if there is a block anywhere here, anywhere if there is a block here, see there is an outer border of first rib which passes here. So if there is, let's say, something related to the rib, if there is some compression due to the rib, okay, there can be a block anywhere here, right? So all of that block, it can be compensated by the scapular anastomosis. So that is the clinical significance of scapular anastomosis. That is the clinical significance of the scapular anastomosis. Okay, clear to you? We're again done with 12 questions. We're moving on to question number 13. We're moving on to question number. We'll talk about the cubital fossa now. We're going to talk about the cubital fossa now, its boundaries, its contents. Cubital fossa, boundaries and contents. The first thing, cubital fossa is a triangular hollow. Cubital fossa is a triangular hollow, and it is homologous to the popliteal fossa. It is homologous to the popliteal fossa. So you have to simply write down the boundaries and you have to write down the contents. In the boundaries, if I show you a diagram, look here. Which is the muscle that is, you can see here? Which is the muscle that you see here? Should I draw a schematic for you all? Let's draw a schematic first of all. So this is your the base of the triangle. I told you it is a triangular content. It is a triangular fossa, right? So if I draw the base of the triangle, this is, look here, this is going to be the lateral epicondyle. I'm making this to be the lateral epicondyle, and here I'm making the medial epicondyle. Here I'm making the medial epicondyle. So if I join the lateral and medial epicondyles, this imaginary line, which I'm calling it as the epicondylar line, which I'm calling as the epicondylar line, that is known as the base of the triangle. It is directed upwards and it is represented by an imaginary line. Then there is a lateral boundary and there is a medial boundary. There is a lateral boundary and there is a medial boundary. Laterally, the muscle that is going is known as brachioradialis. There is a muscle here laterally known as brachioradialis. It's along the radial side, brachioradialis, and medially the muscle will be pronator teres. Medially the muscle will be pronator teres. So the lateral border of pronator teres is the medial boundary, and the medial border of the brachioradialis is the lateral boundary. It is the lateral boundary. So this is how you will write the boundaries of the cubital fossa. The apex is, as you can see, the apex is directed downward and the base is present upwards. It is formed by the area where the apex here, it is formed by the area where the brachioradialis crosses the pronator teres. It is formed by the area where brachioradialis crosses the pronator teres. So that's about the boundaries of the cubital fossa. Now, if I talk about the roof of the cubital fossa, there's also these were the main boundaries. There's going to be a roof, there is going to be a floor, and there are going to be contents, right? So when you talk about the roof of the cubital fossa, what is the most superficial structure that is there in the roof? It is obviously the skin. It is obviously the skin. Under the skin, you will have what? Superficial fascia and deep fascia. Okay. The superficial fascia, it contains your median cubital vein along with cephalic vein and basilic vein, which are connected by the median cubital vein. And I told you along the cephalic vein you have the lateral cutaneous nerve of the forearm, and along with the basilic vein you have the medial cutaneous nerve of the forearm. So you have 5 structures in the superficial fascia of the roof of the cubital fossa. 5 structures here in the superficial fascia itself. Then there is the deep fascia, and after that you have the bicipital aponeurosis, which is responsible for separating the median cubital vein from the brachial artery, and it also allows perforators to pass through it so that the median cubital vein is fixed in the cubital fossa. It is fixed in the roof of the cubital fossa. Then the floor is made up of mainly of the brachialis and some part of the supinator. That is the floor of the cubital fossa. Finally, we move to the contents of the cubital fossa. Do you guys know the mnemonic for contents of the cubital fossa? What is the mnemonic for contents of the cubital fossa? Quickly tell me the mnemonic for contents of the cubital fossa. Very, very famous mnemonic. I think all of you should know this. MBBR. Okay. Any other mnemonic anyone knows? Cool. So I prefer to go with another mnemonic, that is MBBS. Okay. So I usually replace R with S. MBBS. Okay. Because to be technically correct, MBBS is a better mnemonic. I'll show you how. From the medial to lateral side, this is from the medial to the lateral side. So if I start from the medial side, the first structure is M. M is median nerve here, right? It is the median nerve which gives branches to the flexor carpi radialis, palmaris longus, and flexor digitorum superficialis here. Then it leaves the cubital fossa by passing between the two heads of the pronator teres, which are forming the medial boundary. So median nerve, it is on the medial side. So it will obviously go and it will pass between the medial boundary of the cubital fossa, that is between the two heads of the pronator teres. So that is how the median nerve is passing. Okay. Second, you have the two B's. Okay, so it is very important to know that first, is it the brachial artery or is it the biceps tendon? So first, you will have the brachial artery. Remember that. So when you do your physiology practical of measuring the blood pressure, okay, so how do you identify the brachial artery? You ask the patient to flex the forearm, you identify the tendon of biceps and you palpate medial to it. So that is the termination of the brachial artery. So remember that medial to the biceps tendon you have the brachial artery. So first you will have the termination of the brachial artery and beginning of the radial and ulnar arteries. After that you will have the tendon of biceps brachii, and finally you will have the radial nerve. Why am I using the mnemonic S? Why am I saying MBBS? Because to be very technically specific, it is not the radial nerve which is the content, it is the superficial branch of the radial nerve. Radial nerve has two branches here, the superficial branch and the deep branch. Only the superficial branch of the radial nerve is the content of the cubital fossa. So you can go ahead with MBBR also, but remember please that R here should represent the superficial branch of the radial nerve. Okay. So look here now, this is a diagram of the cubital fossa. You can see this is the roof of the cubital fossa, this structure that is seen. You can see the skin and the fascia. And in that you can see that this is the medial cutaneous nerve of the forearm. This is the lateral cutaneous nerve of the forearm that is running in the roof of the cubital fossa, right? What else do you see here? You see the contents of the, you see the boundaries of the cubital fossa. So this is the medial side and this is the lateral side. Medially you will see the pronator teres and laterally you see the brachioradialis. In the floor you will see main muscles brachialis and supinator. Supinator you will see on this side. So this is the, this muscle here is the supinator, and you can see here this main muscle in the floor is the brachialis. Besides that, what are the structures that you see? Medial most structure here, it is the median nerve. Then you see the brachial artery, it divides into the radial and the ulnar artery. So this is the ulnar artery and this is the radial artery. This is the radial artery. So then the radial artery, it gives a radial recurrent branch also. Then besides that, what you see here is the tendon of the biceps. You see the tendon of the biceps brachii. So M, B, B, and then finally you see the superficial branch of the radial nerve, and the deep branch of the radial nerve, it goes under the brachioradialis. It goes under the brachioradialis. So these are the, this is the cubital fossa that you see in a proper actual good diagram, right? This vein that you can see here, this is the vein of the medial side, this is the vein of the lateral side. Laterally you will have the cephalic vein, medially you will have the basilic vein. It has been cut, but if you would have been able to see here the median cubital vein running towards the basilic vein. Okay. And this, what has been cut here, this is the bicipital aponeurosis. This has been cut to show you the median nerve and the brachial artery. So that is how the cubital fossa looks like. That is what you should ideally see. That is what you should draw in a diagram as well. So radial artery is the smaller branch of brachial artery. It is more superficial and it gives a radial recurrent branch. The ulnar artery, it goes deep to both heads of the pronator teres. Remember the median nerve, it was passing between the two heads of the pronator teres, whereas the ulnar artery, it goes deep to both heads of the pronator teres, and therefore it will be separated from the median nerve by the deep head of pronator teres. It gives off the anterior ulnar recurrent branch, it gives off a posterior ulnar recurrent branch, it gives the common interosseous artery which divides into the anterior and posterior interosseous artery, and the posterior interosseous artery will give the interosseous recurrent branch. I know you'll get all these videos for free here on this YouTube channel, that is Let's Crack NEET PG. You can also subscribe to my Telegram channel and you can get the links of all of these videos that I'm making, right? And do remember to share these videos with your friends and hit the like button for this video and subscribe to the channel Let's Crack NEET PG. Okay. So yeah, this is about the tendons of biceps brachii, and I've talked to you about the radial nerves, right? The radial nerve, it descends medial to the lateral epicondyle and it gives off the posterior interosseous nerve or the deep branch of the radial nerve which supplies the extensor carpi radialis brevis and supinator. ठीक है. So about the radial nerve, what I was saying, see, radial nerve, समझो radial nerve को. Radial nerve, it has two branches. Radial nerve, it divides into two in the cubital fossa. It divides into two in the cubital fossa. What are the branches? There is a superficial branch of the radial nerve and there is a deep branch of the radial nerve. The deep branch of the radial nerve, it gives off what is known as the PIN or the posterior interosseous nerve. It gives the posterior interosseous nerve, which is going to supply your extensors, right? And the superficial branch, it is supplying cutaneously. It is giving a cutaneous supply, right? So this is the one that is the content of the cubital fossa. This is running deep to the brachioradialis, and this will ultimately supply, which will also supply the extensors of the forearm and the hand also. In the cubital fossa, the radial nerve, it supplies extensor carpi radialis brevis and supinator. It supplies these two. The clinical anatomy of the cubital fossa, you should know that median cubital vein is the site for IV injections, recording of blood pressure, and during elbow fractures, the supracondylar fracture of humerus, you have injury of nerves here, right? So you guys can also go to the channel Let's Crack NEET PG, and if you go to this YouTube channel, you will find that there is a playlist called as Anatomy Basics. There is a playlist called as Anatomy Basics, and there I have uploaded an entire video on cubital fossa, which you can watch for a quick revision of cubital fossa. Watch it on 2x, and that will make your concepts on cubital fossa crystal clear. Right now, I am doing it as a marathon, so I might be skipping a few things. There, I have covered it in complete detail. So if you are preparing it, especially for your internals, do your cubital fossa very well. For your profs, this will suffice. But if you are preparing for your internals, watch that video separately on cubital fossa. Okay? Question number 14. Now it's time to talk about the radial nerve. This is a very long answer because I'm going to talk about all the branches of the radial nerve. Okay? बहुत ध्यान से सुनना अब. You have to be very careful now because very important topic. Hello, give me 1 minute as a break. You also guys take a 1 minute break. Okay, just have a look at this diagram and then we'll come back to doing this questions, right? So we are almost done with 13 questions. Okay, so let's see how many more do we have. I'll just be back in 1 minute. Okay. So now we're back. Now we're going to talk about completely about the radial nerve, right? So yeah, we talk about the radial nerve. So radial nerve, it begins here in the axilla. It begins here in the axilla, right? So it gives some branch in the axilla as well, right? So what it supplies in the axilla is the triceps. It supplies the long and medial head of the triceps in the axilla. It supplies the long head of the triceps and the medial head of the triceps. Okay, medial head of the triceps is the main head of the triceps. Okay, over 90% of the action of triceps is carried out by the medial head of the triceps. So you supply the medial head twice. So you supply it in the axilla also, and you supply it in the radial groove also. So this is the radial groove. This is the radial groove. So I will again supply the medial head of the triceps, and this time I will also supply the lateral head of the triceps. So I hope you know that triceps, it has three heads, right? So you will supply the medial head of the triceps here, and you will supply the lateral head of triceps here, right? Medial and lateral are supplied in the radial groove. In the axilla, you supply the long and the medial head, right? Then after it moves out of the radial groove, it will go and run on the side of the lateral side of the humerus, all right? And there it will supply the brachioradialis and extensor carpi radialis longus. It will supply two muscles, brachioradialis and extensor carpi radialis longus. Okay? And once it has supplied these two muscles, so remember that these two muscles are supplied above the lateral epicondyle. They are supplied above the lateral epicondyle. Okay, so if there is an injury that is here at the level of lateral epicondyle, there is some sparing of extension because these muscles have already been supplied. Then it passes over the front of the lateral epicondyle. It passes over the lateral epicondyle, right? It passes in front of the lateral epicondyle. And once it passes in front of the lateral epicondyle, it runs into the cubital fossa, where it divides into the superficial branch and the deep branch. The superficial branch, it gives cutaneous innervation to the dorsum of the hand, excluding the nail beds. It will supply how many fingers? It will supply the lateral 3.5 fingers. Excluding the nail bed. Lateral 3.5 fingers, excluding the nail bed on the back of the hand, on the dorsum of the hand. 1, 2, 3, 3.5. Lateral 3.5 fingers, excluding the nail bed, are supplied by the radial nerve. The deep branch, it goes deep to the supinator. Muscle, and there it continues as the posterior introsseous nerve, where it will supply all extensors, including extensor digitorum. So now I hope you understand what is exactly happening here, what is the course of the radial nerve, what are the branches of the radial nerve. It will also supply the anconeus. So it supplies the anconeus from the radial groove, as far as I remember. It supplies the anconeus here from the radial groove only. Supplies the anconeus. Absolutely correct. It will also supply the anconeus muscle above the lateral epicondyle. Right. Thank you. Thank you for pointing that out, Raj Pavan. You're absolutely right. So look here of the radial nerve, the muscular and the cutaneous branches. First of all, radial nerve, it is the thickest branch of the brachial plexus. What is the root value? Root value is C5, C6, C7, C8 and T1. So it has root value from all the roots of the brachial plexus, right? So where are the branches of the radial nerve coming? Okay, so first branches, they are coming in the axilla. Axilla, I told you, it will supply the long head of triceps and the medial head of the triceps, right? Lateral head is not supplied in the axilla. Cutaneous branch here will be the posterior cutaneous nerve of the arm. So remember, the posterior cutaneous nerve of the arm, it is given by the radial nerve. Okay. Then we move ahead. In the radial groove, it supplies the lateral head of triceps, it supplies the medial head of triceps, and like I told you, it also supplies a muscle known as anconeus. It also supplies the anconeus in the radial groove. Okay. And here it gives the posterior cutaneous nerve of the forearm and the lower lateral cutaneous nerve of the arm, right? So the posterior cutaneous nerve of the arm and forearm, both are given by radial nerve. It also gives a vascular branch to profunda brachiae artery in the radial groove. Okay. Then on the lateral side of the arm, I told you two muscles, brachioradialis and extensor carpi radialis longus. Okay. It will also supply proprioceptive fibers to brachialis. It will also give proprioceptive fibers to brachialis. Okay. Brachialis is a hybrid muscle. Brachialis is a hybrid muscle. Why? Because it receives its supply from musculocutaneous nerve, but it also has proprioceptive fibers coming from the radial nerve. Okay. And then this is the deep division of radial nerve, which is called as the posterior introitious nerve. Okay. In the cubital fossa, it will supply extensor carpi radialis brevis and supinator. And in the back of the forearm, it will supply extensor pollicis brevis, extensor pollicis longus, extensor digitorum, extensor indicis, extensor digiti minimi. Right. It will also supply abductor pollicis longus. It will supply abductor pollicis longus. This you can remember separately. So it's very easy to remember once you are aware of the course. Once you are aware of the course, you can easily explain. You can easily explain everything. Okay. And it has some articular branches to the wrist. Okay. The superficial division of the radial nerve, it gives cutaneous supply to the lateral side of the forearm, and it will supply the skin over the snuff box, lateral half of the dorsum of the hand, and it will supply the lateral 3.5 digits excluding the nail beds. Excluding the nail beds. Yeah, so this is the diagram that you can remember. Baki sab bhool jana chahe, but please don't forget to remember the things that are important. Don't forget to remember this diagram. Don't forget to remember everything that we have shown here. Don't forget all of this. Okay, at least try to remember this basic concept. After that, if you can write down everything in points, that's well and good. At least remember the muscular and cutaneous branches. No need to remember the vascular branches or the wrist branches or the joint branches. At least remember the muscular and cutaneous branches. ठीक है? Triceps को oh black है ये तो. Please remember कि triceps is being supplied. Oh again. Please remember the triceps is being supplied. Extensor digitorum is being supplied. Then your extensor carpi radialis longus, brachioradialis, where all these are being supplied. There are branches in the axilla, there are branches in the radial groove, then there are branches on the lateral side of the arm, there are branches in the cubital fossa, there are the superficial branch which gives cutaneous supply, and the posterior introitious nerve which will supply all the extensors. So that is the main takeaway from this particular point. Otherwise, these notes are there for you to remember all the branches, otherwise you can remember from the notes. Axilla में कौन सी आ रही है, ठीक है, रेडियल ग्रूव में कौन सी आ रही है, लैटरल साइड ऑफ आर्म में कौन सी आ रही है, बैक ऑफ फोर आर्म की कौन सी है, क्यूबाइटल फोसा की कौन सी है, एंड सुपरफिशियल डिवीजन व्हिच गिव्स द क्यूटेनियस ब्रांच, वो उसकी कौन सी. Okay, so that should be very helpful to you. That should be sufficient for remembering. Okay, now let's move to question number 15 about lumbricals and interossei. So now we have come to hand, and hand is the part where most of you will get stuck. Hand is the part where most of you will think that let's leave it. Okay, but I will tell you, only do the questions that are present here in this particular video. Okay, uske alawa chahe you can leave the hand, don't study anything in the hand, but at least do the basic important things. Lumbricals, interossei, first carpo-metacarpal joint, anatomical snuff box. At least try to do the main things, right? Let's talk a little bit about lumbricals and interossei. We'll only talk about the nerve supply and the actions. I'm not going to talk about the attachments, right? I'm only going to talk about the nerve supply and the actions, right? So nerve supply and the actions of lumbricals is our topic now. I hope I'm not going too fast anywhere. I hope you are able to understand everything, because I'm assuming that you have read upper limb somewhat. Okay, so please tell me if I'm going too fast anywhere. If anywhere you feel I'm going too fast. Anyone? Okay. So nerve supply and actions of lumbricals. Okay. So about the lumbricals, what you should know about the nerve supply is that the first and the second lumbricals they are unipinnate. The first and the second lumbricals they are unipinnate, and the third and the fourth lumbricals are bipinnate. Do you know what are unipinnate muscles and what are bipinnate muscles? Unipinnate muscles and bipinnate muscles. Unipinnate and bipinnate muscles. What are unipinnate muscles and what are bipinnate muscles? Yeah, so unipinnate muscles, this is how a unipinnate muscle looks like. And for a bipinnate muscle, this is what a bipinnate muscle looks like. This is unipinnate and this is bipinnate, right? Understand unipinnate and bipinnate? In the center, you will have the fibrous thing, and on the sides, you will have the muscular thing. In the center, on both sides. This is a difference between a unipinnate and a bipinnate. I'll draw it in a more proper way if you guys want. This is how a unipinnate muscle would. And as far as a bipinnate, so I've drawn the fibrous part of the septa kind of with the green, and now I've drawn it with the blue here. So you are bipinnate. Okay, I hope this helps you understand. So the first and second lumbricals they are unipinnate, and the unipinnate lumbricals they are supplied by the median nerve. Okay. Third and fourth lumbricals they are bipinnate, and the bipinnate lumbricals they are always supplied by the deep branch of the ulnar nerve. They are supplied by the deep branch of the ulnar nerve. Okay, so this is the nerve supply of lumbricals. Done. What are the actions of lumbricals? Actions of lumbricals. There is again a finger mnemonic. Okay, so lumbricals starts with L. So you will make a L shape with your hand. You will make a L shape with your hand. So there is flexion of the metacarpophalangeal joints and there is extension of the interphalangeal joints of the second to fifth digits. Second to fifth digits. 2, 3, 4, 5. Okay. So flexion of the metacarpophalangeal joints and extension of the interphalangeal joints. This is done by lumbricals. This L shape it is maintained by lumbricals. There is also the role of interossei, but main role here is of lumbricals. Flexion of the metacarpophalangeal joints and extension of the interphalangeal joints. That is done by lumbricals, right? This L shape it is made by lumbricals. Okay. Now we'll come to the palmar interossei. So palmar interossei are on the palmar surface. So there are four in number. There are four in number. Nerve supply of all the interossei are supplied by deep branch of ulnar nerve. All interossei are supplied by deep branch of ulnar nerve. So nerve supply is clear. Nerve supply is clear. Actions, there is a mnemonic, dab and pad. Dab and pad. Okay. Dorsal interossei, they will abduct and palmar interossei will adduct the fingers towards the third digit. So when we consider this abduction and adduction with respect to your hand, the reference axis is the middle finger. The reference axis is the middle finger or the third digit. So adduction is with respect to the middle digit, and adduction is with respect to the third digit, and abduction is also with respect to the third digit. Okay, so this is kept stationary, and rest all are moved with respect to it. Okay. So pad and dab is the mnemonic I just told you for the actions of palmar interossei and dorsal interossei. Pad and dab. Okay. Add is adduction टैब में ab is abduction. So this is going to be palmar interossei. This is going to be dorsal interossei. This is going to be dorsal interossei. This is going to be palmar interossei. Right? Palmar interossei. Very clear to you what are the functions of lumbricals and what are interossei. Was this difficult? So see, these are lumbricals. These are how lumbricals are placed. You can see the first and second, they are unipinnate. The third and fourth, you can see here, they are bipinnate lumbricals. They are bipinnate lumbricals. The first and second lumbricals are unipinnate, so they will be supplied by the median nerve. First and second, they will be supplied by the median nerve. Third and fourth, they are bipinnate. They will be supplied by the ulnar nerve. Okay, that is true for the lumbricals. These are the dorsal interossei. On the dorsal side of the hand, they will take part in abduction, and the palmar interossei, they will take part in adduction. They are located on the palmar surface of the right. There are 4 palmar interossei of the hand, and there are 4 dorsal interossei of the hand. 4 each, right? You guys can hit the like button if you like the video so far. We are on the 16th question now. After this, only relatively few number of questions are left. Hit the like button on the video if you guys like the style of presentation of this video. So next we are going to talk about claw hand and the lesions in which you have claw hand. Let's talk about claw hand and in the lesions in which you will have claw hand. Claw hand will occur when there is hyperextension of the MCP joint and there is flexion of the proximal and distal interphalangeal. Right? That is the definition of claw hand. Hyperextension of MCP joint. So this is the metacarpophalangeal joint. So lumbricals are supposed to flex it. Lumbricals are supposed to flex it. But there is hyperextension of MCP joint and there is flexion of the proximal and distal interphalangeal joints. There is flexion of these joints, right? So that is known as claw hand. Try to make your own claw hand and you will realize how to write this. Okay? What you have to do, you have to make a claw, like an animal makes a claw, to make a claw, and then you simply describe it. There is hyperextension at MCP and there is flexion at both proximal and distal interphalangeal joint. So that's very easy to write. What is claw hand? First thing. Then what are the lesions in which claw hand can be caused? It is caused mainly in ulnar nerve palsy. Where all can you have ulnar nerve palsy? Cubital tunnel syndrome. Okay, cubital tunnel syndrome is in the cubital tunnel. Remember, carpal tunnel syndrome is different. Cubital tunnel syndrome is different. Carpal tunnel syndrome is of the median nerve. Cubital tunnel syndrome is of the ulnar nerve. Okay, it is between the tendons of flexor carpi ulnaris. Then epicondylar region, ulnar groove. There is an ulnar groove on the humerus. There you can have an ulnar nerve palsy, or if the injury is between the elbow and the wrist. It is mainly due to the paralysis of lumbricals, which are supplied by the ulnar nerve. Remember, the third and fourth lumbricals are supplied by the ulnar nerve, which are bipinnate. So this is you see third and fourth lumbricals are damaged. So this is ulnar claw hand. This is ulnar claw hand. Okay. If the median nerve is also damaged, then these lumbricals are also affected, and that is a total, that is called as total or complete claw hand if there is also median nerve damage together. Understand? So if there is weakened intrinsic, okay. So again, let's try to understand this in a little more detail. Let's try to understand claw hand in a little more detail. Okay. It's not just because of weakening of the lumbricals. Okay. It's not just because of weakening of the lumbricals. It's also because the extrinsic muscles, they are not weakened. They remain unopposed. Right. So if lumbricals are gone. Lumbricals are gone. Okay. So, but there are still other flexors here. There are other flexors here, right? There are other extensors here. So the extrinsic muscles which are strong, they will lead to unopposed extension at the MCP joint. They will lead to unopposed extension at the MCP joint. Wait. They will lead to unopposed extension at the MCP joint. The flexor digitorum profundus and flexor digitorum superficialis, they are not innervated by the ulnar nerve. And they will lead to unopposed flexion at the interphalangeal joints. They will lead to unopposed flexion at the interphalangeal joints. The second and the third digits, they are not involved as much as the fourth and the fifth digits in the true ulnar nerve palsy, because they are the innervated by the median nerve. They are the unipennate lumbricals innervated by the median nerve. They have unipennate lumbricals innervated by the median nerve. If both median and ulnar nerve are gone, complete claw hand, as seen in case of Klumpke's paralysis. As seen in case of Klumpke's paralysis. Okay. And the intermetacarpal spaces, they are hollowed because of wasting of the interosseous muscle. Now there's something known as the ulnar paradox. Do you know about the ulnar paradox? Any one of you who knows about the ulnar paradox? There is a complete lecture on the nerves of the upper limb where I have covered all of this in great detail. So you can definitely watch that particular lecture and know everything that is there about the nerves of the upper limb, because this is a very quick summary, guys. I cannot cover each and every point. I can only cover the important ones for your prof examinations. So if you want very great details, there are individual lectures on each of the nerves of the upper limb. Okay, उसमें brachial plexus, radial nerve, median nerve, ulnar nerve, all of these are covered in detail. Axillary nerve, musculocutaneous nerve. I have covered all the nerves of the upper limb together in one crisp lecture. Okay. Tell me right now, do you guys know about the ulnar paradox? What do you guys know about the ulnar paradox? Can you state the ulnar paradox in one statement? Anyone? What is the ulnar paradox? Ulnar paradox refers to the fact that the claw hand deformity, it is more pronounced in case of low injury. It means that if the injury is more distal, the injury is more severe. Okay. So lower lesions are more severe. Yes, beautifully done, Tanya. Lower lesions are more severe than high level lesions in case of ulnar paradox. Why? Because the ulnar nerve, it innervates the medial part of flexor digitorum profundus. In low injury, the flexor digitorum profundus is not paralyzed. So it will bring about flexion of the interphalangeal joints very strongly. It will bring about that flexion very strongly. Okay. Okay. But if the injury is a high injury, the flexor digitorum profundus also gets paralyzed. So both intrinsic and extrinsic muscles are paralyzed. So there is not as much flexion of the distal interphalangeal joints. Get it? You understand that? And you have to understand that if the reinnervation occurs, so the second aspect of the ulnar paradox is that if there is a higher level injury, if let's say there was an injury of the ulnar nerve here at the elbow, okay, and it starts to heal, right? So first the innervation will come back for the flexor digitorum profundus. So the high level lesion gets converted into a low level lesion. So first it will get worsened as the flexor digitorum profundus is reinnervated, and when the patient recovers, it will become totally normal. Hence the use of the word paradox. So you have to understand this concept of reinnervation also when you talk about ulnar paradox. When you talk about ulnar paradox, you have to understand that it is a paradox of reinnervation. Okay. If you want more detail, you can go and watch the lecture on nerves of upper limb. I've covered the ulnar paradox in detail. Yeah. Okay, besides that, in case of claw hand, you will have some other things. You will have sensory loss, okay, over the medial one third of the palm and medial half fingers. You will have vasomotor loss because the sympathetic supply is gone. There is sensory loss, right? There is drying, and then you will have trophic changes including dry and scaly skin, and you will have paralysis of interossei, and you will have more such features. And median nerve lesions, they are more disabling. Why? Because median nerve, it is the main nerve of the forearm. Okay, so you are not able to do gross movements also. You lose gross movements also. So we're done with 16 questions. Okay, now this is question number 17. Okay, forget this numbering, because when I have written the answers for you, I have prepared this for upper limb, I have prepared this for thorax, I have prepared this for head and neck, I have prepared this for lower limb, right? And I prepared this for abdomen. So I've missed out a few questions initially, so I've put them at the end. So, but I have compiled them together in this particular lecture, right? In this lecture, all of them are together. So we can talk about the blood supply of the breast, right? We can talk a little bit about the blood supply of the breast. So we are done with 16 questions. First 16 questions are done. Now this is question number 17 of the upper limb. This is question number 17 related to the upper limb. Did you like the class so far? Did you like the initial part of the class? Are you, do you feel confident about everything? Do you feel like you know upper limb? You will be able to write answers of the upper limb. That if there is a question about upper limb, you will be able to describe something. You'll be able to describe the nerves. You'll be able to describe the vessels. You'll be able to describe scapular anastomosis. All of that. ओके, तान्या के यस में 3-4 एस लग गए हैं. बढ़िया. थैंक यू राज पावन. You guys must be tired. I know you've been watching this video continuously for 3 hours. You guys have been my faithful viewers. And you guys, if you guys want a break, you can let me know. Okay. So all of you are confident? That's great. So let's begin with blood supply of the breast now. So do subscribe to the channel. Let's crack NEET PG. Okay. We are almost reaching 15,000 subscribers. So do subscribe to the channel so that you keep getting updated, because educators, they keep going live, and you do have to subscribe to the Telegram channel also of Let's Crack NEET PG. The link is in the description, right? Okay, so let's talk about the blood supply of the breast now. Now, blood supply of the breast, let's break it down very simply. Okay, first thing, what are the arteries that are going around here? What is the artery? So if this is, let's say, I'll make the human body. Forget how bad or good my diagram is. This is, let's say, the human body, and here you have the breast, right? Here you have the breast. Now, what is the artery that is running here along the breast? What is the artery that is running along the breast? Okay, this artery that is running along the breast, what is that artery? That artery is your internal thoracic artery. It is your internal thoracic artery. I can't start second year subjects. I can only be teaching first prof subjects right now. This is the internal thoracic artery, right? But I'll try to integrate some of pathology or some of pharmacology with your physiology and try to give you a feel of that as well. But right now, let's focus on what we're doing. So this is the internal thoracic artery running on the medial side of the breast. This is running here on the medial side of the breast. And as you can see, the internal thoracic artery, it can give branches here to the breast, right? So the internal thoracic artery is one of the supply of the breast, and it is a branch of the subclavian artery. It is a branch of the first part of the subclavian artery, right? These are known as medial mammary branches. These are known as medial mammary branches. Okay, so that's the first point. Second thing is your axillary artery. The axillary artery, it has a few branches, right? What is the branch from the first part of the axillary artery? So this was your subclavian artery. This was your subclavian artery. This was your axillary artery. That supplies the breast, right? So I was saying the axillary artery, it has a few branches here, right? So axillary artery, the first part, it gave a branch known as superior thoracic artery. So it will go downwards towards the breast. This is from the first part. Then coming from the second part, you will have the lateral thoracic artery and you will have the thoracoacromial artery. These two branches. So they will also be supplying the breast. So branches of the axillary artery, they are going to supply the breast. Branches of the axillary artery are going to supply the breast. And the lateral branches of the posterior intercostal, they are also here to supply some of it. Okay. Now, one very important tip that I will give you for your examination is that when you are writing anything, you write two things separately. Whenever you're asked about the blood supply, you write the arterial supplies and the venous supplies separately. You write the arterial supplies as well as the venous supplies. Because sometimes what happens is, whenever you are asked about the blood supply, people often forget to mention the venous supply. Okay? All you have to do is write down venous supply and you will write down accompanying veins. Unless there are some specific venous drainage, you will write down accompanying veins. So please do remember to write that there is also a venous supply. That is also part of the blood supply, right? There is an arterial supply and there is a venous supply. So don't forget to write the venous drainage. All right? Talking about the blood supply of the breast receives its supply first from the internal thoracic artery, medial mammary branches. Second, it receives supply from superior thoracic, lateral thoracic, and thoracoacromial artery. Third, it receives arterial supply from the lateral branches of posterior intercostal artery. Right? Then the veins, they will first converge and they will form a. Okay, so if this is your breast, this is your nipple, this is your breast. These are the veins running here, right? These are the veins running here. They will first form an anastomotic circle around the nipple. Then the superficial set, it will drain into the internal thoracic vein, right? And some veins of the neck. And the deep set, they will go to the axillary artery and the posterior intercostal veins, right? So that is how you will write the blood supply, including 3 arteries, and then you will describe the anastomotic circle, the superficial veins, and the deep veins. Okay, and the superficial lymphatics and the deep lymphatics, they will obviously accompany the veins, right? Write down the arterial supply, write down the venous drainage, and that should be enough for you. Right? Let's move ahead and talk about the clavipectoral fascia and the structures piercing the clavipectoral fascia. Let's talk about the structures piercing the clavipectoral fascia. So there is a separate lecture known as breast and clavipectoral fascia in case you guys want to read about it. There's a separate lecture that I've made on breast and clavipectoral fascia. You guys can go and watch it as well. But for this particular question, I'll mainly be covering what is the clavipectoral fascia and what are the structures piercing it. So first, I'll talk about the structures piercing the clavipectoral fascia. Um, Structures piercing the clavipectoral fascia. What are the structures piercing the clavipectoral fascia, right? There's a mnemonic for this, and that mnemonic is very simple. CLTL. Can anybody enumerate these structures for me? CLTL. Anybody tell me the names of these structures? Very simple to remember. There is a vein, and there's a nerve, and there is a artery, and there are lymphatics. So what are the names of these structures? Very good. Cephalic vein, lateral pectoral nerve, and thoracoacromial artery along with lymphatics of the axillary group of lymph nodes. Done. Let's move ahead and talk about clavipectoral fascia. Let's talk about clavipectoral fascia. Clavipectoral fascia here, it begins here under the clavicle. It encloses first the subclavius muscle. Then these two layers of the clavipectoral fascia, they join, and then they will move downwards. Then they will split to enclose. Okay, what is bhag milkha bhag, Raj Pavan? They will split to enclose. They will split to enclose the P minor. They will split to enclose the P minor. Once P minor has been enclosed, when P minor has been enclosed, then it will again further join, and then it will form the suspensory ligament. It will form the suspensory ligament which will hold the axillary fascia in its place. Which will hold the axillary fascia in its place. It will hold this axillary fascia in its place. It will keep the axillary fascia taut, right? And in front of the pectoralis muscle, you had the pectoral fascia. You had the pectoral fascia. So this is the clavipectoral fascia. It's very important to remember that it encloses two muscles, subclavius muscle and P minor, and it is being pierced by CLTL structures. It is pierced by CLTL structure, right? Medially, you will have the external intercostals of the upper intercostal spaces. अच्छा ये तो छोड़ो अभी के लिए छोड़ दो. Relations are clavicle. छोड़ो. Let's move to question number 111. That is, what are the contents of the axilla? जल्दी से बता दो contents of the axilla. Very easy. Contents of the axilla shouldn't take you even 5 seconds. Very good. But you all have made one very basic mistake. You all have made one very basic mistake. The first content of axilla, the first content of axilla that you should never forget to write is fat. The main content of axilla is the fat. Everything else is secondary. The main content in the axilla is fat. Okay, it is filled with fat. The main content in the axilla is fat. Don't forget to write fat. Okay, first thing. Then you've written right, you've written axillary sheath, that's another content, right? Axillary artery is another content, axillary vein is another content, axillary lymph nodes is another content where you will have the central axillary lymph node, central lymph node, right? So all of these axillary tail of Spence, which is coming from the breast, right? That is also a content. Beautifully done. Okay. But please, long thoracic nerve and intercostobrachial nerve, they are also contents of the axilla, cords of the brachial plexus. But please don't forget to write fat. Okay. Fat is the most important content of axilla. Okay. Baki contents, I know you guys know, but my point that I wanted to emphasize here was please don't forget to write fat as a content of the axilla. Please don't forget to write fat as a content of the axilla. Okay. Chalo. Question number 102 about the deltoid muscle. What is the deltoid muscle? ठीक है देखिए कितना रह रहा है Okay, we're done with almost 133 slides. We have total of 180. So see how much more time we take. The deltoid muscle is a delta-like or triangular muscle. So that is why it is known as the deltoid muscle, right? Delta-like or triangular, right? Deltoid muscle. Okay. So we'll start talking about the deltoid muscle. Where does the deltoid muscle take its origin from? Okay. The origin of the deltoid muscle is from the anterior border and adjoining surface of the lateral one-third of the clavicle, the lateral border of the acromion process, and the lower lip of the crest of the spine of the scapula, right? So if you look at the deltoid muscle, if you have a look at the scapula, you will see that the origin of the deltoid, it is from the lateral surface of the clavicle, that is the outer surface of the clavicle, the lateral border of the acromion process, and the lower lip of the spine of the scapula. So it is mostly on the posterior surface. So it is taking place on the posterior surface, right? And the acromial part of the deltoid is a multipennate muscle, right? It is a multipennate muscle. It has 4 septa of origin and they converge to 3 septa of insertion on the deltoid tuberosity. Just have a look here. You can see there are 4 septa of origin and they are converging to 3 septa of insertion on the deltoid tuberosity, right? See here. Clear? The origin is here. Yeah, there are some origin on the spine of the scapula. There is origin from the lateral fibers of the acromion process. There is origin of the anterior fibers from the lateral clavicle. So, what are the 3 kinds of fibers here? What are the 3 kinds of fiber here? There are anterior fibers which are taking origin from the clavicle, lateral fibers which are taking origin from the acromion process, posterior fibers which are taking origin from the spine of the scapula. They're forming the bulk of the deltoid muscle and they are inserting on the deltoid tuberosity on the humerus. It's very prominent. If you see a humerus bone, you will be able to easily appreciate the deltoid tuberosity. Okay. The insertion is on the deltoid tuberosity. Hi Shreyashi. What are the nerves? What is the nerve supply of the deltoid? I'm sure you're aware the nerve supply of the deltoid is axillary nerve. Nerve supply of the deltoid is the axillary nerve, that is C5, C6. Axillary nerve C5, C6, right? And actions of the deltoid, there are multipinnate acromial fibers. They are responsible for abduction. They are very powerful abductors of the arm. And why are they? Why is this a very strong muscle? Because of the multipinnate arrangement. Multipinnate arrangement allows you to condense more muscle fibers in a small volume, right? So multipinnate acromial fibers, they are powerful abductors of the arm, and they're very strong because of the multipinnate arrangements. Please remember, the acromial fibers or the lateral fibers are powerful abductors. The anterior fibers are responsible for flexion and medial rotation, and the posterior fibers are extensors and lateral rotators. So very simple, anterior fibers are flexors and medial rotators, posterior fibers are extensors and lateral rotators. So deltoid is overall a very important muscle, and you have to remember the function of at least these multipinnate acromial fibers. It's not very difficult to understand. देखो ये जो आगे वाले fibers हैं, they will pull it forward and they will medially rotate it. So they will flex and medially rotate. The posterior fibers, they will pull it backwards. So they will extend and laterally rotate. These lateral fibers, they will contract like this and they will abduct the arm. They will abduct the arm like this. Okay. So very simple to understand the actions of deltoid, nothing complicated here. And what about its paralysis and clinical anatomy? We talk about the paralysis. If there is an intramuscular injection, deltoid is a very common site of intramuscular injection, and you try to give it in the middle of the muscle to avoid injury to the axillary nerve. Why? Because axillary nerve, it runs in the upper part where it is winding around the surgical neck of the humerus. So you take three fingers from the surgical neck of the humerus and you give the injection below it in the middle of the muscle, right? Testing the deltoid, you abduct the arm against resistance. You try to apply resistance here and you ask the patient to abduct the arm. So that is how you will test the deltoid. Then axillary nerve damage, we've already talked about this. When there is a dislocation of the shoulder or fracture of the surgical neck of the humerus, you will have rounded contour, paralysis of the deltoid, and sensory loss called as regimental badge. Sensory loss called as regimental badge. So we are done with 102 questions, not 102 questions per se. So see, this was question number 17. This was question number 18. This was question number 19. This will be question number 20. We're done with 20 questions so far. This is question number 21. We're done with 20 questions so far. Right? So are you guys again having any doubts anywhere? You guys ask really less doubts. ऐसा लगता है कि सब समझ आ रहा है तुमको. Any doubts that you guys have, please clear them out right now so that we can move ahead. Okay. Let's talk about biceps brachii. Let's talk about biceps brachii, the first muscle that you probably know of your body. In case anybody of you is planning to take a plus subscription, you can use my referral code Chetanya10 to take a plus subscription. It's my name, and 10 is the percentage discount that you can get, right? So let's begin with biceps. right now, and we'll talk about biceps and brachialis both together, their nerve supplies. So biceps is supplied purely by the musculocutaneous nerves, that is root value C5, C6. Brachialis, on the other hand, it is a hybrid muscle. It is a hybrid muscle. Why? Its motor innervation is purely from the musculocutaneous nerve. That's fine. Its motor innervation is same as biceps, but it has proprioceptive, that is sensory fibers, which are coming from the radial nerve, So therefore, it is a hybrid muscle. Please remember this point, that it has proprioceptive fibers coming from radial nerve. Brachialis receives proprioceptive fibers. So which are the muscles that are supplied by musculocutaneous? What are the muscles supplied by musculocutaneous? Can you tell me the muscles supplied by musculocutaneous? Which muscles are supplied by musculocutaneous nerve? Tell me muscles supplied by musculocutaneous nerve. Right. That's correct. The mnemonic is BBC. BBC. Biceps, brachialis, and another muscle is coracobrachialis. Another muscle that is supplied here is coracobrachialis. That is also being supplied by the musculocutaneous nerve. Cool. Now we know about the biceps, the nerve supply of the biceps brachii, also the nerve supply of the brachialis, right? Nerve supply of biceps and brachialis. We know this. Now let's move to a little more about the actions of the biceps. I hope you know that biceps is the strong supinator in the flexed forearm. Bicep not only is a flexor, okay, you might have commonly heard of this action of the biceps, but one of the very important actions of the biceps is supination. One of the very common action of biceps is supination, especially in case of a flexed forearm. So when you are doing some screwing movements, all right, when you are inserting a screw into something, so this is the movement, right? So your forearm is flexed and you constantly pronate, supinate. So in that action, biceps is the major muscle involved. It is the muscle that you cannot do anything else without. मतलब इसके बिना तुम screwing नहीं कर सकते हो. If you want to attach a screw into wood, you will not be able to do it without biceps. You will not be able to do it without biceps. Okay. Flexion, both brachialis and biceps are involved in flexion. So it is also a muscle of flexion, but its main function is supination in case of flexed forearm. Okay. So please try to clear that misconception out that the only function of biceps is flexion or something. Okay. Supination इसका बहुत main function है. One of the more major functions as compared to flexion, right? Because you also have brachialis for flexion. Its short head is a flexor of the arm, and its long head it prevents upward displacement. Right? So next we'll move to, after biceps, let's move to triceps. Triceps. So please try to share this video with your friends so that they can also prepare for the prof exams, and they can also have access to all these notes. And the entire question bank along with the answers. Okay. So you've asked me about the shunt and spurt muscles, right? The shunt and spurt muscles, they are part of the general anatomy, so I'll prefer to cover them there only. Okay. What is a shunt muscle and what is a spurt muscle, right? So I'll try to cover that in general anatomy. It is in my head. I'll cover. I should I take a class on general anatomy as well, where I'll do Hilton's law. I'll do shunt and spurt muscles and some basics regarding the development of a long bone. All of that. Okay, I'll take a class on general anatomy and we'll try to cover that there. Okay. So right now let's talk about triceps, the nerve supply, the actions, and the applied anatomy. So first, triceps, the nerve supply. Each head of the triceps, it receives its branches from the radial nerve. Triceps, each head receives its branches from the radial nerve. I had shown you in a diagram before that in the axilla, the long head and the medial head are going to be supplied, and in the radial groove, the medial head and the lateral head are going to be supplied. So in the axilla, long head and medial head; in the radial groove, the medial and the lateral head, both are going to be supplied. Okay. Good evening, Shashank. Good evening. Yeah. So the actions of the triceps, it is the powerful extensor of the elbow. Although to be honest, elbow, it does not require much active extensor. Alright, it can get extended with the help of gravity. But it is a very powerful active extensor of the elbow, and its long head also helps in the extension and reduction of the arm at the shoulder, and it will support the head of the humerus in the abducted position. The main role in the entire triceps is of the medial head. Okay, long and lateral heads, they have very minimal role. Okay, the main role is of the medial head, and that is why medial head is being supplied twice. It is also being supplied in the axilla. It is also receiving branches when the radial nerve is in the radial groove. So medial nerve, it is very important for the triceps. And even if the medial nerve is injured in the radial groove, I'll just tell you in the clinical anatomy points. So see here, this is the long head. This you can see here is the long head coming from the infraglenoid tubercle, right? And this is the rest of the triceps that is shown to you, the three heads you can see. Applied anatomy, I was saying, if the radial nerve is injured in the arm, in the radial groove, if the radial nerve which is injured in the arm, right? In the arm, the medial head and the lateral heads are being supplied, right? So but in the axilla, the medial head has already been supplied and the long head has also been supplied. So if there is an injury here, in the radial groove, the triceps, it escapes complete paralysis. Why? Because the two nerves that are supplying it arise in the axilla. Two of the nerves that are supplying it arise in the axilla. The nerve for the medial head and the nerve for the long head. So therefore, it escapes paralysis if it is injured in the arm. If it is injured in the arm on the radial groove, right? So therefore, it will escape paralysis. And you will have sparing of triceps extension. Because I told you the medial head is main. In the axilla, the medial head gets supplied. So even if there is an injury here, it is not much of an issue because medial head has already been supplied once. Okay. Then clinical testing, you will test it by extension of the flexed forearm against resistance. That is the clinical testing. Nothing much complicated here. Now we are coming to the next question. So we were done with how many questions? 20. Question number 21. This question number 22. Now we are moving to question number 23. This is for carpal tunnel syndrome. Let's do carpal tunnel syndrome. What is carpal tunnel syndrome? I told you two things. One, there is cubital tunnel syndrome, and one is carpal tunnel syndrome. Okay. So carpal tunnel syndrome, you now know it is of the median nerve. Cubital tunnel syndrome, it is of which nerve? Which nerve undergoes cubital tunnel syndrome? Tell me, which nerve undergoes cubital tunnel syndrome? Which nerve do you think undergoes cubital tunnel syndrome? Ulnar nerve. Very good. Tanya and Jasbinder, Sangeet, all of you have answered correctly. The ulnar nerve, it is the nerve that undergoes cubital tunnel syndrome. So when I talk about carpal tunnel syndrome, again, like I told you, every nerve injury, it has to be described under 4 headings. It has to be described under 4 headings. Motor loss, sensory loss, vasomotor loss, and trophic loss, right? It has to be described under these 4 headings. And compression of median nerve in the carpal tunnel is the cause of cubital tunnel syndrome, carpal tunnel syndrome. So it is occurring at the wrist. So what will be there? First of all, median nerve, it supplies the thenar eminence. It supplies the thenar eminence. So there are muscles here in the thenar group. 3 of the muscles of the thenar group. All the muscles of the thenar eminence, they are supplied by the median nerve. So that is, there is wasting of thenar eminence, and one of the muscles of the thenar eminence is called as opponens pollicis, which is responsible for opposition of thumb. So thumb, it becomes like this. It becomes adducted like this, and it is not able to carry out opposition. So therefore you will have ape-like hand. You will have ape-like hand. Apes, they do not have the power of opposition, and they have an adducted thumb. So power of opposition is lost. So that is wasting of thenar eminence. So that is what you have to write here. Ape-like hand. Done. First point. Wasting of thenar eminence. Second thing, hypoesthesia to light touch on palmar aspect of lateral 3.5 digits. Alright. So lateral 3.5 digits, they are the medial side. The lateral 3.5 digits, they are being supplied by which nerve? The lateral 3.5 digits. The ulnar nerve is supplying the medial ones, right? But the lateral ones, they are being supplied by the median nerve, right? So there is hypoesthesia to light touch. Okay. So the lateral 3.5 digits are gone, but there is sparing of the skin over the palm. There is sparing of skin over the thenar eminence. Why? Because the palmar cutaneous branch, it goes superficial to the flexor retinaculum. Later I will show you the flexor retinaculum, and I will show you that the median nerve, when there is if this is the carpal tunnel, the median nerve, it will divide. The median nerve, it divides here, and the main median nerve, it goes beneath, and it gives the palmar cutaneous branch, which goes above the flexor retinaculum. The palmar cutaneous branch, it goes above the flexor retinaculum, right? So therefore the skin over the thenar eminence, it is spared. Remember this, skin over the thenar eminence, it is spared. It is one of the characteristic features of carpal tunnel syndrome, sparing of the skin over the carpal tunnel. Okay, so Mariam Mahevish is writing the answer for a previous question, and okay, right. So remember these 3 characteristics: ape-like hand, hypoesthesia to light touch of the digits. So basically, sensory loss of digits, sparing of, see here, motor symptom अगर मैं कहूँ तो क्या होगा? Motor symptom is thenar eminence is gone. Thenar eminence is gone. Okay, first and second lumbricals will also be affected, but main loss is of thenar eminence. So ape-like thumb or ape-like hand. Second is sensory loss. Sensory loss. Okay, remember there is lateral 3.5 digits are gone. Lateral 3.5 digits are gone, including the nail beds, but sparing of palm, but sparing of thenar eminence, skin of thenar eminence, sparing of skin of palm, right? So that is what you have to remember. Why? Because the palmar cutaneous branch, it passes over the carpal tunnel or over the flexor retinaculum, right? See here, this is the flexor retinaculum, this is the median nerve. The median nerve, it was going here and it passes underneath the carpal tunnel, but it gives off a palmar cutaneous branch which passes over the flexor retinaculum, which passes above the flexor retinaculum. So this palm is spared, but there is loss of sensation of the digits. Digits are gone, palm is spared. I hope you understand this now. This diagram should help you understand what I am talking about. The palm is spared, but the digits are lost. 3.5 lateral 3.5 digits, including their nail beds, right? So thenar muscles, except adductor pollices, are supplied by the median nerve. They are gone. L1 and L2, lumbricals, first and second lumbricals, they are gone. And digits, the sensory supply of digits is gone. So that is the loss that is going to be there in terms of motor and sensory loss. So because of paralysis of thenar muscle, the patient also has positive Froment sign. It is a sign of median nerve injury, and paper holding test is also positive. Okay. So there are some motor changes, there are some sensory changes, there are some vasomotor changes, and there are some trophic changes. Motor changes, I've told you, there is ape or monkey like thumb because of loss of opposition, right? And the index and the middle finger, they lag behind while making a fist because of paralysis of thenar muscles and lumbricals, because of paralysis of lumbricals, right? So the index and the middle fingers are also affected. There is a flattened thenar eminence. Sensory changes, you know, there is a loss of sensation over lateral 3.5 digits, but sparing of arm. Vasomotor changes, since there is sensory loss, there is arteriolar dilation. The skin will feel warmer. The skin is drier. There is absence of sweating. And trophic changes, the skin is dry and scaly. There is atrophy of pulp and nails will crack easily. Okay. So main motor and sensory changes you cannot forget. Vasomotor and trophic are very simple. So that is how you will write the carpal tunnel syndrome. That is how you will present the carpal tunnel syndrome, and you will get your marks. Okay. So please remember carpal tunnel syndrome. It's very, very important. It's a very important question. Okay. So we're done with carpal tunnel syndrome. I think you have to know something about carpal tunnel syndrome. It is seen in males and females of this age. They complain of attacks of pain during night, and it is more common because of your laptop and computer work. And you do a Fallon's test for carpal tunnel syndrome, and acutely flexed wrist, it will cause a lot of pain. So that is called as Fallon's test. That you do it for carpal tunnel. Right. So we're now moving to what is the flexor retinaculum. What are the structures passing above? What are the structures passing below? What are the attachments of the flexor retinaculum? Right. Let's talk about the flexor retinaculum. Okay. So this is question number 24. Flexor retinaculum. Let's take a 5-minute break, guys. I'm pretty tired. I'll just drink some water and I'll go to the washroom. Please excuse me. Meanwhile, you can have a look at this diagram. Okay, we're back. Let's go ahead and complete the flexor retinaculum. Right. So when I talk about the flexor retinaculum, you have to know about the attachments of the flexor retinaculum and the structures that pass under it. And the structures that pass under it. Right. So when you talk about structures that pass under it, let me first do that. What are the structures passing under the flexor retinaculum? Under the flexor retinaculum. What are the structures passing under the flexor retinaculum? That is known as it's said that there are 9 structures passing under the flexor retinaculum. Okay. Now you will think how to memorize 9 structures, right? But this is very stupid because there are only 3 structures passing under the flexor retinaculum. How? It is 2 into 4 plus 1. This 9 is 2 into 4 plus 1. What is this one structure here? That is median nerve. That is median nerve. Yes, from and sign, it is also used to test ulnar nerve palsy. Your main answer should be ulnar nerve palsy only. You're right, Raj Pavan. But it is also used to test median nerve. It is used for testing of both ulnar and median nerve. It's a little different concept, but from and sign it is used. Some authors will also say that it is also used for median nerve. Okay, you're right in your own respect that from and sign it is mainly for ulnar nerve palsy. From and sign it is mainly for ulnar nerve palsy. You're right. You look at your BDCs, it is also given in median nerve testing. Okay, so that's why I had included that in that answer. But otherwise, to be very your BDC actually says for median nerve also from and sign, but otherwise from and sign as a characteristic is for ulnar nerve, right? So this one structure that I was talking about the structures passing under the flexor retinaculum. I was talking about structures passing under the flexor retinaculum. There are 9 structures, 2 into 4 plus 1. This plus 1 is the median nerve. You obviously know that the median nerve passes under the flexor retinaculum. That is why there is carpal tunnel syndrome. There is carpal tunnel syndrome. Now, what are these 2 other structures? They are the flexor digitorum superficialis and flexor digitorum profundus. So 4 tendons of flexor digitorum superficialis and 4 tendons of flexor digitorum profundus. So therefore you have 9 structures that pass 4 tendons, and 1 median nerve. Very simple. FDS, FDP and median nerve. These are the structures passing under the flexor retinaculum. Please remember that flexor carpi radialis, it does not pass under the flexor retinaculum. I'll just tell you why. Okay, so flexor retinaculum, what it does is it bridges the anterior concavity of the carpals, right? It bridges the concavity of the carpals. What is the medial attachment of the carpet of the flexor retinaculum? The pisiform bone and the hook of Hammett, right? That is the medial attachment, right? And the lateral attachment is the tubercle of scaphoid and crest of trapezium. Tubercle of scaphoid and crest of trapezium. Even if you don't remember the exact terms, please remember pisiform and Hammett here on the medial side. Okay, and please remember scaphoid and trapezium on the lateral side. I hope you know the mnemonic here that we use to write down the carpal bones. She looks too pretty. Try to catch her. I hope you know this. So pisiform and Hammett, scaphoid and trapezium. Right? These are the boundaries of the flexor retinaculum. These are the boundaries of the flexor retinaculum or the attachments. So you will write pisiform, H hook of Hammett, S is tubercle of scaphoid and crest of trapezium. These are the boundaries of or the attachments of. So yeah, the thing about flexor carpi radialis is that it does not pass under the flexor retinaculum. It passes between the two slips of the flexor retinaculum. The flexor retinaculum, it splits into two and it forms superficial and deep layers. And the flexor carpi radialis, it passes through its own compartment and it does not pass under the flexor retinaculum. It passes between the two layers of the flexor retinaculum. So we are not including it here. So you can see this is the flexor retinaculum, this is the flexor retinaculum, and you can see here it is splitting into two. It is splitting into a upper and lower layers. So flexor carpi radialis has its own compartment where it is located, and that is known as the compartment for the flexor carpi radialis. And here it is between the superficial and deep layers of the flexor retinaculum. So below the flexor retinaculum, you can see here the median nerve is present. There is the tendons of the flexor digitorum superficialis are present. The tendons of the flexor digitorum profundus are present. All right. There is a bursa here known as the ulnar bursa, right? And what else can you see here? Yeah, you can see flexor pollicis longus. It is with the radial bursa. So you can basically see the radial bursa, and along with that there is the flexor pollicis longus. Flexor pollicis longus. That is also there. It is. I have not mentioned it separately when I was telling the structures because it is related to the radial bursa, but it is also passing under the flexor retinaculum. All right. Above the flexor retinaculum, what do you have? You have the ulnar nerve and the ulnar artery. All right. You will also have the palmar cutaneous branch of the ulnar nerve. So the ulnar nerve and its palmar cutaneous branch, both of these they pass above the flexor retinaculum. Whereas median nerve passes below the flexor retinaculum, and palmar cutaneous branch of median nerve, it passes above the flexor retinaculum. It passes above the flexor retinaculum. Besides that, you have the tendon of palmaris longus. So this diagram can come for you to draw. Very simple to draw it. Okay. And here are the hypothenar muscles on the medial side, and on the lateral side you will have the thenar group of muscles. Okay. Is this clear to you? You can do 2 into 4 plus 1. Besides that, you can also write flexor pollicis longus. Okay, because it is there in the radial bursa. And besides that, you know that the flexor carpi radialis, it is not located inside. It is inside its own space, right? So there is a medial superficial slip which is known as the look here. If I have to be very strict, right? This is the, let's say this is the flexor retinaculum. So it has a superficial slip on the medial side and it has a deep slip on the lateral side, right? So this superficial slip, it encloses the ulnar nerve and the ulnar artery, and this deep slip, it encloses the tendon of flexor carpi radialis. So the medial superficial slip, it is also called as the volar carpal ligament. It is attached to the pisiform bone, and the ulnar vessels and nerve will pass deep to it. So you can see the ulnar artery and the ulnar nerve, they will pass deep to it. Yes, you do not include the flexor carpi radialis in the structures passing under the flexor retinaculum. Please remember this. You do not include the flexor carpi radialis in structures passing under the flexor retinaculum. You mention it separately that flexor carpi radialis is situated between the lateral deep slip and the flexor carpi retinaculum, right? Flexor retinaculum, right? ये वीडियो अपलोड हो जाएगी यार, टेंशन मत लेना. This video will also get uploaded. You can share it with your friends. Saifullah, don't worry. Okay, and it is the lateral deep slip. It is attached to the trapezium, obviously, and it gets converted into the tunnel for the tendon of flexor carpi radialis. So I told you this is known as the tunnel for the flexor carpi radialis. So look here. Flexor retinaculum, which are the things that are going to be deep to the flexor retinaculum? Median nerve, right? 9 tendons, 4 of flexor digitorum superficialis, 4 of flexor digitorum profundus, and 1 tendon of flexor pollicis longus, which is inside the ulnar bursa, which is related to the ulnar bursa. So ulnar bursa, radial bursa, I will mention separately, right? Yes. Then superficial to flexor retinaculum, you have the ulnar vessels and ulnar nerve in the under the volar carpal ligament, which is called as the roof of Guyon's canal, right? This ulnar nerve, it passes through the Guyon's canal here, right? It is also known as pisciohamate tunnel, right? Then you have the origin of the thenar and hypothenar muscles superficial to the flexor retinaculum. You have the palmaris longus tendon, the palmar cutaneous branch of ulnar nerve, and the palmar cutaneous branch of median nerve. So these are all the relations that are there of the flexor retinaculum. You have to know, very important, what passes deep to the flexor retinaculum and what passes above the flexor retinaculum. This diagram, please keep in your mind, in your head, in your heart. Again, I ask you, are we clear? Now we come to question number 25. We are going to talk about mid-palmar and thenar spaces. We are going to talk about mid-palmar and thenar spaces. Just have a look here. This is your hand and I have cut it here. If I have cut it here in the palm, right? Little above, in front of the retinaculums, right? So what all can you see here? What all can you see here? You will be able to appreciate that there are two places where you have some empty space. Okay, so you have in the middle of the palm, you have a mid-palmar space, and towards the thumb, you have the thenar space. Towards the thumb, you have the thenar space. So there is a mid-palmar space and there is a thenar space. So if I ask you, what is the shape of the thenar space? What is the shape of the thenar space? It is triangular in shape. You would agree with me? And the thenar space is also, the mid-palmar space is also somewhat triangular, right? So that is there about their shapes. That is the first thing, not very important. We'll come to the second thing. Where is the mid-palmar space located? It is under the inner half of the hollow of the palm. And this is on the outer aspect or the outer half of the hollow of the palm, the thenar space. Okay. Then the extent, the proximal extent is given to you. The distal extent is given to you, right? And the communications are more important. What I want to show you is the communications, right? So in the forearm, there is a space that communicates with the spaces of hands, and that is known as the forearm space of Parona. That is known as the forearm space of Parona. So infections of the hand, they can go through these spaces to the forearm space of Parona. That is why these spaces are important. And they are connected to the facial sheaths of the mid-palmar one. See here, this is connected ahead to the facial sheaths of the third and fourth lumbricals, L3 and L4. The thenar space, it is connected to the facial sheath of the first lumbrical, right? So the communication of this palmar and thenar spaces, they're important. The mid-palmar space, it communicates with the facial sheaths of the third and fourth lumbricals, whereas the thenar space, it communicates with the facial sheath of the first lumbrical, whereas both of them, they communicate with the forearm space of Parona. Okay, now what are their boundaries? You should be able to write the anterior boundary, the posterior boundary. Okay, not very difficult. You have to write here. You can see these are the flexor tendons. These are the flexor tendons. So you can see the flexor tendons of the third, fourth, and fifth digits, the second, third, fourth lumbricals, and the palmar aponeurosis. Here you will write flexor tendon of the first digit, first lumbrical, palmar aponeurosis, and muscles of the thumb. So anterior boundaries are very, very easy to write. These are the anterior boundaries of the thenar space, anterior boundaries of the mid-palmar space. Okay. So after that, laterally here you will have the intermediate palmar septum, and medially you will have the medial palmar septum. In case of the thenar space, the medial boundary will be the intermediate palmar septum, and the lateral boundary will be the tendon of flexor pollicis longus with the radial bursa. Okay. Again, the more important point here is the drainage. Okay. To drain the mid palmar space, you have to give an incision in the third or the fourth webbed space. That is where you have to give an incision. To drain the thenar space, you give an incision in the first webbed space. You give an incision in the first webbed space. So what are the important points when you talk about the mid palmar and the thenar spaces? What are the important points? First important point is regarding the communication with the forearm space of Parona and the facial sheath of the lumbricals. That is the first important point. The second important point is the drainage by incision in the third or fourth web space for the mid palmar space, and for the thenar space you will have posterior incision in the first web space. So these are the two main important points regarding mid palmar and thenar space: the communication and the drainage. Please remember at least that. If you forget rest everything, that's fine. If you forget rest everything here, that's fine, but please remember the communications and the drainage. Now I will talk about pulp space. Okay, this is less commonly asked, but it is also sometimes asked in the form of a viva question, right? So that is why I am also discussing pulp space with you, right? Here, right? After pulp space, we have to talk about extensor retinaculum, after which we'll talk about elbow joint, after which we'll talk about first carpometacarpal joint, then we'll talk about a few nerves, we'll talk about the rotator cuff. Okay. Only some part is left. Let's talk about the pulp space. Pulp space is present in the tips of the fingers and tip of the thumb. Here the subcutaneous fat, it is arranged in tight septal compartment. So you can see here that in the space here you will have fibrous septa. You will have fibrous septa. So there are fibrous compartments into which the pulp space is divided by these fibrous septa. These fibrous septa, they will divide the pulp space into these multiple compartments. That is what the fibrous septa are going to do. Alright, that's the first thing that you should know. Then second thing, you should know that infection of the space is called as Whitlow. Infection of the space is called as Whitlow, and it is you have a very severe throbbing pain of the digits, right? You have a very severe pain here. And how do you drain these? You drain them by a lateral incision. So you give an incision on the side. You give an incision on the side so that you open all the compartments and you avoid damage to this tactile tissue, because here you have a lot of sensory endings. If you give a cut here, you will damage the sensory tissue here. So you will give an incision on the lateral side. Okay. Then there is one thing known as, if there is a infection here, if there is an infection here, so you will realize that this vessel gets damaged, this vessel gets damaged, this vessel gets damaged, but there is sparing of this vessel because this is located outside the pulp space. This is located outside the pulp space. So distal phalanx of the distal phalanx, right? There is sparing of 1/5, the proximal 1/5. So there is avascular necrosis of the distal 4/5 of the terminal phalanx due to occlusion of vessel, and the proximal epiphysis, it escapes since its artery does not transverse through the fibrous septa. I hope you have understood this point. Look here, I'll take you to the screen. Let's say this is the terminal phalanx. Let's say this is the terminal phalanx. It is being supplied by its own arteries, right? It has its own arterial supply, and that artery, it is dividing into 5 parts. There's a branch to epiphysis, and then there is a branch to the shaft. All right. So this is 4/5 and this is 1/5, right? And the one that is supplying the shaft, right? The one that is supplying the shaft, that is part of the pulp space. That is part of the this is part of the pulp space, and there are fibrous septations here. So if there is an infection here, the pressure here will increase and there will be necrosis of these arteries. So you will have avascular necrosis. Avascular means you have lost vascularity of this region. So there will be avascular necrosis of distal 4/5. Avascular necrosis of distal 4/5 of the distal phalanx, right? But there is sparing of the 1/5, that is the epiphysis. Sparing of epiphysis. Why? Because the artery supplying the epiphysis, it does not pass through the pulp space. It does not pass through the pulp space. So that is a characteristic of Whitlow infection. Okay. It's 4 o'clock and we are done with 25 questions. Right. This is question number 26 now. Deep relations of extensor retinaculum. Deep relations of extensor retinaculum. Achha, you guys only tell me what do you guys know about the anatomical snuff box. I have not covered the anatomical snuff box separately because I was planning to cover it in this question only. So you tell me what do you know about the anatomical snuff box. First of all, tell me the boundaries. First of all, tell me the boundaries of anatomical snuff box. Then tell me of the contents. Second, tell me the boundaries and the contents. Boundaries and contents of anatomical snuff box. So tell me three contents of the anatomical snuff box. Then tell me the medial boundary, tell me the lateral boundary, tell me the base, tell me the floor, and the roof is obviously skin. You can leave out the roof. Okay. So extensor pollicis longus is present medially. That's right. Extensor pollicis longus is present medially. Then you are saying which muscles are present laterally? Abductor pollicis longus, and extensor pollicis brevis. Right. Extensor pollicis brevis and abductor supported by abductor pollicis longus. That's true. This is the lateral or the radial boundary. Then base is formed by the styloid process of the radius. Base is formed by the styloid process of the radius. And the floor is formed by the carpal bones. Floor is formed by the carpal bones, right? Scaphoid. Floor is formed by the scaphoid, and some part of trapezium is also there. Okay. Now the contents are important. The contents have the radial artery. Okay. Radial artery is there. You have the cephalic vein. You have the radial artery. You have the cephalic vein. You also have a nerve. Okay, we are done with artery. We are done with vein. There is also a nerve here. Which is the nerve here? Can you tell me which is the nerve in the anatomical snuff box? Let's write it in a better way. Tell me the nerve in the anatomical snuff box. Superior radial nerve. Okay, superficial branch of radial nerve. That's right. If a question is there to you, what is the anatomical snuff box? Let's consider this to be question number 26. Your question will be anatomical snuff box, boundaries and ends. Right? So that is the question to you. So now if I say boundaries, you have these boundaries. Okay, medial boundary, extensor pollicis longus, lateral boundary, extensor pollicis brevis and abductor pollicis longus. Then you will have the styloid process of radius, which will form the base. Styloid process of radius. Then in the floor you will have two things. In the floor you will have carpals, so you will have scaphoid and you will have trapezium, right? So this is what you will have as boundaries, and surrounding roof you can write skin. Roof you can write skin. Whereas when you talk about the contents, you will write three contents. The first main content is the radial artery. The first main content is the radial artery. It passes through the anatomical snuff box, the deep branch, right? So then after radial artery, you have cephalic vein, which is coming on the lateral side of the arm, the forearm. And the third thing is the superficial branch of the radial nerve, which was coming from the cubital fossa. So the superficial branch of the radial nerve, it is a content of both the cubital fossa and the anatomical snuff box. So superficial branch of radial nerve, it is a content of both the anatomical snuff box as well as the cubital. So this is question number 26, where you will describe the anatomical snuff box. Let's move to question number 27, where we talk about deep relations of the extensor retinaculum. Deep relations of the extensor retinaculum. Okay. So there are 6 compartments in which we study the deep relations of the extensor retinaculum. Just have a look here. This is the radius, this is the ulna. So we numbered all these compartments: first, second, third, fourth, fifth and sixth. And once we do that, it becomes very easy. Why? Because the first and the third compartments, they are boundaries of the anatomical snuff box. They are towards the radial side, so they are boundaries of the anatomical snuff box. You can see here, what is the lateral boundary? The lateral boundary was extensor pollicis brevis supplemented by adductor pollicis longus. Abductor pollicis longus. What was the lateral boundary? Sorry, the medial boundary. The medial boundary was extensor pollicis longus. So first and third compartments, they're very easy because they're nothing but the boundaries of the anatomical snuff box. They're nothing but the boundaries of anatomical snuff box. First and third, they are done, right? Now second, you will have, so now this is radius. So what will you will have over radius? Extensor carpi radialis longus, extensor carpi radialis brevis. Very logical. Extensor carpi radialis longus and extensor carpi radialis brevis, they will pass through the second compartment. Okay. Now what will pass through the over the ulna? First, what will pass over the ulna? The most medial structure, that will be the extensor carpi ulnaris. That will be the extensor carpi ulnaris. In between them, here you have extensor digitorum. You have extensor digitorum, right? And you have extensor indicis. You have extensor indicis in the fourth compartment. And fifth compartment is extensor digiti minimi. Very simple to remember. If you go from here to here, you will have the various extensors. The first and third compartment are anatomical snuff box. Second compartment is extensor radialis. Fourth compartment is extensor digitorum and extensor indicis. Fifth compartment is extensor digitorum minimi. And sixth compartment is extensor carpi ulnaris. This is what you were looking for. Okay. The fourth compartment is what you have to pay slightly more attention to. Slightly more attention to it. Right? Fourth compartment, besides the extensor tendons, there are also some vessels passing. There is some vessel, some nerve also passing through the fourth compartment of the extensor retinaculum. Okay. You can see all the other compartments, they have some tendons passing through them, but the fourth compartment, it has extensor digitorum, it has extensor indicis, but it also has one nerve and one set of vessels passing through it. Okay, so the nerve that passes here is the posterior intraosseous nerve. Can you tell me posterior intraosseous nerve is a branch of which nerve? Posterior intraosseous nerve, it is a branch of which nerve? The posterior intraosseous nerve, it is a branch of which nerve? Radial nerve. It's a branch of the radial nerve. So along with the posterior intraosseous nerve, which is the artery that you have here, here you have the anterior intraosseous artery. Now how come has the anterior intraosseous artery come along with the posterior intraosseous nerve? ये क्या लोचा हुआ है भाई? पीछे posterior intraosseous nerve है, but साथ में artery कौन सी है? Anterior intraosseous. Posterior intraosseous nerve and anterior intraosseous artery. How is this possible? Okay, and somebody is telling me, Raj Pavan is telling me that anterior intraosseous nerve, it is a branch of median nerve. Absolutely true. Absolutely true. But here you have the anterior intraosseous artery traveling with the posterior intraosseous nerve. Now, why does this happen? Can you tell me how come does the anterior intraosseous artery come to lie with the posterior intraosseous nerve? How does that happen? How does the anterior intraosseous artery come to lie with the posterior intraosseous nerve? How is that possible? It pierces the distal intraosseous membrane. Absolutely correct. The anterior intraosseous artery, it pierces the intraosseous membrane, and that is why it comes and lies posteriorly along with the posterior intraosseous. Why it comes and lies posteriorly along with the posterior intraosseous. Much is clear? As much is clear, then we can proceed further. Now let's talk about the elbow joint. Next, we'll have to talk about the elbow joint. See, now we will probably complete this in another half an hour or in another 1 hour. So you can see that upper limb is nothing but matlab I am explaining it to you and it is taking to me around 5 to let's say 5 hours or let's say 5 to 6 hours. Okay, somewhere between 5 and 6 hours. So upper limb is not, if you have to revise on your own, this will, if you watch this video on 1.5x or let's say 1.75x, if you can watch it this video, or if you have to just read the notes, this will hardly take you 1 or 2 hours. Once you have seen this video, this will hardly take you 1 or 2 hours, so you can then stop worrying about upper limb totally. Okay, so that's why do send this video to your friends. This is really going to be useful for them as well. So we talk about the elbow joint now, muscles and actions of the elbow joint. You continue. So let's now talk about the Elbow joint. Let's now talk about the elbow joint, the muscles and the actions of the muscles which are related to the elbow joint. So first of all, it's very important for you to remember. Just give me a second, guys. Right. So I have scheduled a class, another class I've scheduled right now, guys. So I just wanted to tell you all about it. So that was what I was doing right now. 6:30 p.m. today, I'm going to take a class on basics of ECG, right? I'll take a class on basics of ECG, and we'll at least try to cover the important thing, that is the limb bleeds. We'll try to do the limb bleeds and we'll try to do the leads of the ECG. Okay. Uh, okay, so try to attend that class if you guys want. So we'll try to do that at 6:30 p.m. today. Basics of ECG, right? So I'll tell you a little bit about P wave, Q wave, R wave, S wave, T wave. Okay, I'll tell you what is the definition of Q wave, what is the definition of an R wave, what is the definition of an S wave, right? What are the various segments, and I'll mainly discuss what are the leads and how do you place the limb leads of an ECG, or how do you what is the Goldberg central terminal, all of that. We'll discuss that in detail because that is forming a basic concept. Otherwise, the questions in your entrance examination, they are likely to be from certain abnormalities of the ECG rather than from the leads and everything. But that's something that you need to know, and it's much more important for your first prof, right? So elbow joint, let's talk about the muscles and the actions of the elbow joint. So first, elbow joint is a, what is the type of joint? Type of joint, it is a hinge joint. It is a hinge joint. Second thing, what are the articular surfaces of the elbow joint? What are the articular surfaces of the elbow joint, right? So it involves the radius, and it involves the ulna, it involves the humerus. So it is a joint which is formed from three bones. It is a joint formed from three bones. What are the three bones? The radius, the ulna, and the humerus, right? These are the three bones that are involved in formation of this particular joint. The upper surface of the head of radius, it articulates with the capitulum of humerus. The trochlear notch of ulna, it articulates with the trochlea of humerus. So humerus, it has a projection known as trochlea. The ulna has a trochlear notch. Similarly, the head of the radius, it fits into the capitulum of the humerus. So that is the articulation that is there in the hinge joint. And there are some ligaments around it, the fibrous capsule, the anterior and posterior ligaments, the radial and ulnar collateral ligaments, right? And there is some blood supply, which is, there's an anastomosis around the elbow joint, okay, which we are not doing in detail, but you should just know that there is an collateral circulation that exists around the elbow joint. And the median radial nerves, the musculocutaneous nerves, all of these nerves will supply the joint. The important thing is regarding the movements. Since it is a hinge joint, it is a uniaxial joint, so it is only allowing movement of one plane, that is flexion and extension. It is only allowing flexion and extension. Flexion is carried out by brachialis, biceps brachii and brachioradialis. These are the three flexors of the upper limb of which joint? Elbow joint. Flexors of the elbow joint. And what are the extensors here? Extensors, mainly the extensor is medial head of triceps brachii. Anconeus is more or less a stabilizing muscle, but it is also said to have a role in extension. So these are the muscles here that are related to the elbow joint. You should know the nerve supply of each of these muscles. So what is the nerve supply of brachialis and biceps brachii? What is the nerve supply of these two muscles? Can you tell me the nerve which supplies these two muscles? What is the nerve that supplies brachialis and biceps brachii? Nerve supply. Right. Musculocutaneous nerve. The nerve is musculocutaneous. Which is the nerve that supplies brachioradialis, and which is the nerve that supplies triceps and anconeus. Are they all supplied by the same nerve, or are they supplied by different nerves? ये क्या हो गया? ठीक है. The musculocutaneous, it arises from the lateral cord. That's true. I'm asking that what about the nerve supply of Okay. So one thing that you have missed here in the nerve supply of brachialis is that Tanya has caught is the fact that brachialis is also supplied by the radial nerve. There are proprioceptive fibers of the brachialis that are coming from the radial nerve. Very important to mention when you are telling me about the nerve supply, right? Brachioradialis, triceps and anconeus, all three are supplied by the anconeus. All three are supplied by the anconeus. All three are supplied by the radial nerve. Sorry, all three are supplied by the radial nerve. Anconeus is supplied in the spiral groove. Triceps is supplied in the axilla and spiral groove. Brachioradialis is supplied on the lateral side of the arm, above the lateral epicondyle, right? So this is the nerve supply regarding the muscles that are carrying out the various movements at the elbow joint. Yeah. Next, we are going to talk about the first carpo-metacarpal joint. It is very important, very important to know about. Why? What is the type of joint of the first carpo-metacarpal joint? Tell me the type of joint. Type of joint for first carpo-metacarpal joint. What is the type of joint here? Okay, so Sangeet is saying pivot. Tanya and Raj Pavan, you guys are right. It is a saddle type of joint. It is a saddle variety of synovial joint, which is having a concavo-convex articular surface, right? So type of joint is synovial joint. Subtype is saddle joint. That's absolutely true, right? And then it is the only carpo-metacarpal joint which has a separate joint cavity. It is the only other have a common joint cavity. This is the only carpo-metacarpal joint which has a separate joint cavity, and the movements at this joint are much more free. So you can see that the rest of the fingers, they cannot move as much as the thumb. The thumb can move much more as compared to the other finger. So your thumb is much more mobile than the other fingers. It is therefore the only carpometacarpal joint which has a separate joint cavity, and that is responsible for why your thumb has much greater mobility as compared to the other carpometacarpal joints, and it is the saddle type of synovial joint. It is the saddle type of synovial joint, right? Saddle type of synovial joint. What is saddle joint? You have a concavo-convex articular surface. You have a concavo-convex articular surface. ठीक है? What are the movements and what are the muscles involved? So this is the first carpometacarpal joint, right? And these are the movements that take place at this particular joint. These are the movements that take place at the first carpometacarpal joint. These are the movements that take place. Okay. Movements are flexion, extension, abduction, adduction, circumduction, and opposition. Flexion is basically similar to medial rotation, and extension is similar to lateral rotation. Extension it coincides with lateral rotation. Okay. So now when we talk about flexion, for flexion you have, first of all we'll talk about the main muscles. The name is almost there in the names of the muscles only. So for flexion you have flexor pollicis brevis. Okay. For extension you have extensor pollicis brevis and extensor pollicis longus. These are the boundaries of anatomical snuff box. For abduction you have abductor pollicis longus and abductor pollicis brevis. Adduction you have adductor pollicis. What is the nerve supply of adductor pollicis? Nerve supply. Can you tell me the nerve supply of adductor pollicis? Nerve supply. Okay. So movement of flexion is done in the plane of the palm. So flexion, this is flexion and this is extension. Flexion, extension. So this is done by flexor pollicis brevis. This is done by extensor pollicis brevis and extensor pollicis longus. So flexion and extension, they are done in the plane of the arm. Abduction and adduction, they occur in abduction, basically is at right angles to the plane of the palm. So if I am doing this, that is abduction. So that is done by abductor pollicis brevis and abductor pollicis longus. And when I am bringing it back, that is adductor pollicis. And you all are right, it is innervated by deep branch of ulnar nerve. It is innervated by deep branch of ulnar nerve. Rest muscles of the thenar group, they are innervated by the median nerve, whereas adductor pollicis is innervated by the deep branch of ulnar nerve. It is innervated by the deep branch of ulnar nerve. Is that correct? And circumduction, it is a combined movement of flexion, extension, abduction, adduction. You have a combined movement of flexion, extension, adduction. That is a combined movement. What is opposition? What is opposition? Opposition is carried out by opponens pollicis. Opposition is carried out by opponens pollicis, right? And it is the, what do you do in opposition? You first abduct your thumb, then you flex it, and then you adduct it, right? So that is with some simultaneous rotation. So this is opposition. This is opposition, right? So you know the movement of opposition, and it is contributed by opponens pollicis. Now one more thing, opponens pollicis and flexor pollicis brevis, they are supplementing each other. So in flexion you also have opponens pollicis, and in opposition you also have the role of flexor pollicis brevis, because here also you require flexion. Here also you require flexion. Yeah, this provides the pinching ability. That's true, and it is a unique feature of humans, right? Flexor pollicis brevis is also supplied by the ulnar nerve occasionally. That's true. Flexor pollicis brevis is sometimes also called a hybrid muscle. It is also supplied occasionally by the ulnar nerve, right? Deep branch of the ulnar nerve. So I've told you about the movements at the first carpo-metacarpal joint. We are almost nearing the end of this lecture. So I told you that this was question number 20. I forgot. Tensor retinaculum was question number 27. And this is question number 28. Elbow joint. This is question number 29. So we are done with 29 questions now. This is question number 30. Nerves related to the humerus and their injuries. This is very simple. At the surgical neck of the humerus, you have the axillary nerve. In the radial groove, you have the radial nerve. And at the behind the medial epicondyle, you have the ulnar nerve, right? So which is the nerve which passes in front of the lateral epicondyle? Which is the nerve which passes in front of the lateral epicondyle? Nerve passing in front of the lateral epicondyle. Nerve passing in front of the lateral epicondyle. Which is the nerve which passes in front of the lateral epicondyle? The radial nerve. That's true, right? So the ulnar nerve, it passes behind the medial epicondyle. The ulnar nerve, it passes behind the medial epicondyle. Ulnar nerve passes behind the medial epicondyle, and the radial nerve, it passes in front of the lateral epicondyle. The radial nerve, it passes in front of the lateral epicondyle. Okay. Do you understand the radial nerve, the ulnar nerve, the radial nerve in the radial groove, and the axillary nerve? So these are the three nerves that are said to be related. Axillary nerve at the surgical neck, radial nerve at the radial groove, and ulnar nerve at the behind the medial epicondyle. So these three nerves are related to the humerus and they have their particular injuries. So if there is an injury of the axillary nerve, can you tell me what will happen? If there is an injury of the axillary nerve, what will happen? There will be paralysis of the deltoid, there will be regimental badge, there will be a flattened shoulder, all of that. If there is a paralysis of the radial nerve in the radial groove, what is spared? What is spared if there is paralysis of the radial nerve at the radial groove? What is going to be spared if there is paralysis of the radial nerve at the radial groove? Which movement will be spared? Yes, extension of triceps is spared if there is injury of the radial nerve in the radial groove. There will be sparing of extension of the triceps. Why? Because it has already been supplied in the axilla, the medial and the long heads, they have already been supplied in the axilla by the radial nerve. So there is sparing of extension of, that is there, that is true here, right? Then the ulnar nerve, like you all know, it passes behind the medial epicondyle. So if there is ulnar nerve injury behind the medial epicondyle, you will have loss of movement of, you will have the injury that is equivalent to a higher ulnar lesion, where you will have uh, less severe claw hand along with sensory loss, less severe claw hand along with sensory loss. So that is about the nerves related to the humerus and their injury. So your Viva examiners, they will sometimes ask you which are the nerves which are present in relation to the humerus. So it is very important to remember that the ulnar nerve, it passes behind the medial epicondyle, and the radial nerve, it passes in front of the medial epicondyle. Front of the lateral epicondyle. Cool. So let's move ahead. And so I told you axillary nerve damage. You will have, it is possible if there is dislocation of the shoulder or fracture of the surgical neck. Radial nerve injury, it is also called as honeymoon or Saturday night palsy. Now, why is it called as honeymoon palsy? Can you tell me why radial nerve injury in the radial groove is called as the honeymoon palsy? Do you know why it is called as the honeymoon palsy? Why is radial nerve injury in the radial groove called as honeymoon or Saturday night palsy? Okay, and it can also be due to fractures of the shaft of the humerus or an intramuscular injection that is given at a lower level. Yeah. Why is radial nerve injury in the radial groove called as honeymoon palsy or Saturday night palsy? See, the word Saturday night palsy, it is used for both. It is also used for radial nerve injuries in the axilla. It is also used for radial nerve injuries in the radial groove. It is used for both of these injuries. Now, why is that? Can you explain this? Why is this called as honeymoon palsy? You see what will happen if you are gone for a honeymoon or for a Saturday night. So Saturday night it is assumed you will party and you will probably sleep with your partner. So you will, or you will, if, even if you sleep alone, you will lie with your head on your arm or your partner's head maybe on your arm, and that will bring lot of pressure here, and that might cause a radial nerve injury in the radial groove. So that is the reason. Yeah, lying on the head in the for the couple, right? It's true. So that's why this is called as honeymooners palsy, radial nerve injury in the radial groove. So we've done axillary nerve damage. We've talked about radial nerve damage. So there will be weakness of extension, but there is no loss of extension, right? Of the arm. There is sparing of extension of the arm, but there is wrist drop because wrist extensors like extensor carpi radialis longus, they are damaged. Sensory loss over narrow strip on the back of the forearm and the lateral side of the dorsum of the hand, right? That is the sensory nerve supply of the radial nerve. Weakening of brachioradialis will cause wrist drop. Weakening of wrist extensors, including extensor digitorum, will cause finger drop, and there will be difficulty in supination because supinator and brachioradialis are also damaged, and there will be sparing of elbow extension because triceps are spared. So these are the features of the injury in the radial groove. These are the features of injury in the radial groove. Wrist drop, finger drop, but no elbow drop. No elbow drop. If the injury is in the axilla, you have elbow drop, wrist drop, finger drop. If the injury is in the radial groove, what is spared? Your elbow drop is spared. You have wrist drop and finger drop. If the injury is at the level of lateral epicondyle, then what happens? The wrist drop is also spared. Why? Because brachioradialis is supplied above the lateral epicondyle. And if the injury is of the posterior interosseous nerve, finger drop will still be there. Okay. So now you know sparing of elbow drop and sparing of wrist drop. When does that happen? For details of this, you should definitely go to my lecture on nerves of the upper limb. I had shared the link with you in the start of this class. You can, I'll share it again also if you ask me. That will take me 1 minute only. Nerves of I've shared it. You can save it and you can watch it later to see regarding the nerves of the upper limb. If you have any doubts regarding the nerves anywhere. Yeah, I've discussed all the levels of the lesions also, upper injury, lower injury, all of that. What about ulnar dislocation of the medial epicondyle? You will have claw hand deformity affecting the ring and the little fingers. You will have hypothenar wasting, loss of abduction, which is known as card test. Prominent sign will be positive because there is loss of adduction of thumb, and there will be weakness of wrist flexion. So, like Raj Pavan correctly pointed out, loss of adduction of thumb in the prominent sign positive is a feature of ulnar nerve injury, right? The feature of ulnar nerve injury. So this is what you should prefer. Ulnar nerve injury is the answer you should go for. If ulnar nerve is not in the option, only then you should go for medial nerve. Okay, now let's talk about, so on, I think last second, this is the second last question, the third last question, fourth last question, fifth last question, fifth last. Five more questions are left. Yeah, five more questions are left. This was question number 30. We're done with 30 questions. There were a total of 35 questions in my lecture. So I had selected out 35 questions for your upper limb that are the most important questions, most important 35 questions of the upper limb. So that should suffice for your prof preparation and for your internal preparation as well. So how many of you have been watching the video from the start? How many of you have been watching the video from the start? It's been almost 4 hours 40 minutes to stream. How many of you have been watching the video from the start? I think Raj Pavan has been watching from the start. Need something to eat. Just give me 2 minutes. I'll be back. Meanwhile, you can have a look at this diagram of the rotator cuff. Try to understand the diagram of the rotator cuff. I'll mark some points for you. Rotator cuff. Okay. So try to have a look at the subacromial bursa. Try to have a look at the deltoid. Try to have a look at the deltoid here as well. Try to have a look at teres minor. Try to have a look at infraspinatus, supraspinatus, and try to have a look at the subscapularis bursa. Try to have a look at scapularis, axillary structures, teres major, and yeah. So try to have a look at these structures and try to appreciate the sequence in which they are present. I'll be here in a minute. Okay, so Sangeet has also been here since the start. Hmm. Amin has also been here since the start of the class. Hello. Right. Now, if I come to talk to you about the rotator cuff, it is also called as the musculotendinous cuff or the shoulder cuff, right? It is a fibrous sheath which is formed by four flattened tendons, okay, which blend with the capsule of the shoulder joint and they will strengthen it. Okay. So look here, what are the four muscles which will form the rotator cuff? What are the four muscles forming the rotator cuff? This muscle here that you see, this is known as subscapularis. This muscle here is known as subscapularis, right? After that, the muscle on top here, that is supraspinatus. This is infraspinatus, and then this is teres minor, right? So this is the muscle that is attached on the lesser tubercle, and these three muscles they are attached to the greater tubercle. These three muscles they are attached to the greater tubercle. So the mnemonic that you can use here is SITS, right? You can use the mnemonic SITS. You use this mnemonic SITS, right? To understand the structures, to understand their basement. and you know SIT they will attach on greater tubercle, and this will go to the subscapularis, will go to the lesser tubercle. Basically, they will merge, their tendons will merge, and they will form a flattened sheath around the shoulder joint, and that is known as the rotator cuff. That is known as the rotator cuff. Other things that you should appreciate about the rotator cuff is that between the supraspinatus and the acromion, there is a subacromial bursa which will prevent the rubbing or friction here of the supraspinatus during abduction, right? Then here you have a subscapularis bursa, that is between the subscapular muscle, and it will basically be around the shoulder joint right here. And so this subacromial bursa, this is very important. This is present above the supraspinatus. And when you talk about this entire structure, it is generally the shoulder joint capsule. It is lacking inferiorly, so there is inferior displacements are more common. So acromion, I've told you. Supraspinatus, I've told you. Then the long head of biceps tendon, it can be seen passing through the joint capsule. The long head of biceps can be seen passing through here. Then the deltoid is present on the side. Infraspinatus, glenoid, fossa, glenoidal, labrum, teres minor. Then posteriorly here you have winding around the surgical neck of the humerus. You have the posterior circumflex humeral artery along with the axillary nerve. Okay, and it is a branch of the axillary artery. The posterior circumflex humeral artery is a branch of the axillary artery. Along with it, medially running is the axillary vein. So you have the long end of the triceps here, and besides that you will have the teres major present. Yeah, you can see teres major, you can see teres minor, and yeah, that's about it. You can see the coracoid process. Okay, and coracoid process और acromion को जुड़ता हुआ coracoacromial ligament again, right? And you can make out the cephalic vein here. That's pretty much everything that you have to see here in the diagram. So I've told you the tendons also: subscapularis, supraspinatus, infraspinatus, teres minor, and the tendons, they will blend with each other and they will go and join with the capsule, right? But the capsule is deficient inferiorly. The rotator cuff, it is deficient inferiorly, so there can be antero-inferior dislocations. They're very common because the rotator cuff is deficient inferiorly, and it basically strengthens the capsule and it will steady the head of the humerus. That's the function of the rotator cuff, right? Then if I move on to question number 32, what are the branches of the musculocutaneous nerve? So I told you that the mnemonic for its nerve supply is BBC, biceps brachialis and coracobrachialis. The root value is C5, C6, C7. Root value is C5, C6 and C7. And the nerve supply is biceps brachii in the arm, brachialis, and coracobrachialis in the axilla. It also supplies the elbow joint, and it continues as the lateral cutaneous nerve of forearm to the lateral part of the forearm skin. Okay, so musculocutaneous nerve, it is important that it forms the lateral cutaneous nerve of the forearm, which runs along which vessel? It runs along the cephalic vein. Can you tell me from where does the medial cutaneous nerve of forearm come from? Can you tell me from where does the medial cutaneous nerve of forearm come from? Where does the medial cutaneous nerve of forearm come from? What is the origin site of medial cutaneous nerve of forearm? Where does the medial cutaneous nerve of forearm arise from? Absolutely correct. It arises from the medial cord. Absolutely correct. It arises from the medial cord. Like you guys said, it arises from the medial, right? So look here, this is the musculocutaneous nerve. It is coming from C5, C6, C7. It is piercing the coracobrachialis. That is the identification of the muscle. It pierces the coracobrachialis. That is the identification of the nerve also. That is the identification of the muscle also. Muscle that is going to be pierced by a nerve is the coracobrachialis muscle. And if you see coracobrachialis being pierced by a nerve, that nerve has to be the musculocutaneous nerve. That nerve has to be the musculocutaneous nerve. Then it goes into the arm and supplies the biceps brachii and brachialis. It will also give a branch to the elbow joint. Then it will go medial. Then it will go where it goes. It goes towards the biceps of brachii, a tendon of biceps of brachii. lateral to the tendon of biceps brachii, and it forms the lateral cutaneous nerve of the forearm, which will supply the lateral part of the forearm skin, right? So that is how the nerve is continuing. That is how the nerve is continuing. So next we are going to talk about ulnar bursa and the radial bursa. Do you remember the ulnar and the radial bursas? Do you remember the ulnar and the radial bursas? Right? We studied them when we did the retinaculum, when we did the flexor retinaculum. We'll talk about the ulnar and the radial bursa and how they get commonly affected. How are they commonly getting affected? So we will talk about the ulnar and radial bursas now. So ulnar bursa infection, it is generally secondary to the infection of the little finger. It is secondary to the infection of the little finger, and it may also spread to the forearm space of Paruna. Yeah. And if there is an ulnar bursa infection, it usually results in a hourglass swelling. Why is it a hourglass swelling? Because there is part of the swelling is in the palm, part of the swelling is in the distal part of the forearm, and in between them there is a constriction due to the flexor retinaculum. So it is a hourglass like swelling. The ulnar bursa swelling is like a hourglass. It is an hourglass swelling, and it is also called as the compound palmar ganglion. The radial bursa infection is generally due to the infection of the thumb, right? So that's how you can make out this. This is the ulnar bursa. So if there is a swelling of the ulnar bursa, it becomes swollen here and it becomes swollen here. That has an hourglass like appearance. That has an hourglass like appearance, right? Which sand will drip. And this is the radial bursa. It is connected to the thumb. So an infection of the thumb, it may spread to the radial bursa, and an infection of the little finger, it may spread to the ulnar bursa. So have you heard of the fact that why we don't, have you done physiology, hematology practicals? Physio में have you done hematology practicals? Hemat के practicals कराते हैं ना, finger prick. Have you done these practicals? Finger prick. Have you done these practicals? Have you done these practicals? Did they tell you why we don't prick the little finger, or why we don't prick the thumb? What is the reason why we don't prick the thumb, or why we don't prick the little finger? What is the reason for that? Anyone? Why we don't prick the little finger, or why we don't prick the thumb in our hematology practicals? You have done hematology practicals in your finger prick, where you have to prick the finger, you have to take out a drop of blood, discard the first drop. No? Okay. So we don't prick the thumb, or we don't prick the little finger, because the thumb is attached via the radial bursa here to the forearm, and the little finger is attached via the ulnar bursa. It is attached to the ulnar bursa. So because the thumb is connected to the radial bursa and the little finger is connected to the ulnar bursa, infections of the thumb here can spread to the radial bursa, and infections of the little finger can spread to the ulnar bursa. And we don't want that spread of infection to come here, right? So therefore, we avoid finger pricks in the thumb or the little finger, because they are connected to radial and ulnar bursa. So the infection will also spread. So therefore, you should never prick your thumb or your little finger in hematology. Okay? Via the infection may spread to the forearm, and the reason is they are connected to the radial bursa and they are connected to the ulnar bursa. That's the reason, right? Pilon finger can occur. Okay, very great. Great. So the link for the 6:30 classes here. I put the link for the 6:30 class in the description. You guys can set a reminder. Okay, so I've done. I put the link on my Telegram channel as well. So it's also there on the Telegram channel of Let's Crack NEET PG. That is t.me slash Let's Crack NEET PG. Right. So you can access the link of the 6:30 p.m. class from there as well. Yes. So this is done. Now I will move to question number. So question number 33 is done. This was question number 33 in our series. Now we will move to question number 34. This is the second last question for today. This is the second last question for today. Sangeet, this is the second last question. We'll be done after that. Okay. So the question is saying the direction of fibers of the interosseous membrane and functions of the interosseous membrane. What are the directions of fibers of the interosseous membrane? So first of all, interosseous membrane, it is an example of syndesmosis. Interosseous membrane is an example of syndesmosis, and it constitutes the middle radioulnar joint. It constitutes the middle radioulnar joints. Fibers, these fibers, they will run downward and they will run medially from the radius to ulna. So it is important to know that these fibers, they run from the radius to the ulna. Why is this important to know? You tell me. Because the wrist joint, can you tell me what are the articulating surfaces of the wrist joint? What are the articular surfaces of the wrist joint? The wrist joint is between the carpals and which bone? Is it between the carpals, radius and ulna, or between carpal and ulna, or between carpal and radius? What are the joints involved in the wrist joint? What are the various bones involved in the wrist joint? Tell me just the out of radius and ulna, is only one of them involved or are both of them involved? In the wrist joint, what is the scene? Quickly. You guys can hit the like button if you liked the video so far. Please do share it with your friends as well. I would really appreciate that. Right. So no. Ulna is not involved. It's only the contribution of carpals and radius. Only contribution of carpals and radius. So since only radius is involved at the wrist joint, if you lift a weight with your hand, right, it will only get transmitted to the radius. So the weight also has to go to the ulna. So the fibers, they run. Okay, this is the styler process. So they will run downwards and medially from the radius to the ulna. They will run downwards and medially to the ulna from the radius. That is the direction of fibers. So that the weight transmission is equally distributed between the radius and the ulna, right? So fibers run downward and medially from the radius to the ulna, and inferiorly there is an aperture for passage of anterior interosseous vessel. So I told you that anterior interosseous artery and anterior interosseous vein, they will pierce the interosseous membrane distally and they will go along with the posterior interosseous nerve. So there is an aperture for this piercing. So there is an aperture for passage of anterior interosseous vessels to the back of the forearm, right? So that is why in the fourth compartment of the extensor retinaculum, what were the structures in the fourth compartment of the extensor retinaculum? Can you name these structures? Can you name the structures in the fourth compartment of the extensor retinaculum? What were the structures? Quickly. Okay, jaldi batao. What were the? So there are four structures in the fourth compartment. That is one way. Yeah, fourth compartment है तो 1, 2, 3, 4. Four structures होंगे इसमें. Tell me the four structures that are there in the fourth compartment. Right. So you're right. The extensor digitorum, extensor indicis, anterior interosseous artery, and posterior interosseous nerve. So anterior interosseous artery is coming into the posterior compartment, right? So that is about the interosseous membrane. And now what are the functions of the interosseous membrane? It binds the radius and the ulna, right? First of all, it binds the radius and the ulna and it will keep them together. That's the first function. Second function, it is providing attachment to many muscles. So a lot of muscles, they will take attachment from the interosseous membrane. The third function that I told you, is that it transmits force, including weight, which is applied to the radius through the hand to the ulna. Why? Because radius is the main bone of the wrist joint, while ulna is the main bone of the elbow joint. Radius also takes part in the elbow joint, but ulna does not take part in the wrist joint. So radius is the main bone of the wrist joint, and ulna is the main bone of elbow joint. So weight that is there in your hand, it has to be transmitted to your body. So hand, wrist, shoulder, body, right? So from the hand, it goes to the radius. From the radius, it goes via the interosseous membrane to the ulna. From the ulna is the main bone in the elbow joint. From the ulna, it goes to the humerus, and then from the humerus, it will go through your appendiculars, through your axial skeleton. Okay. Kimaya, you didn't understand something? Kimaya has joined us. I think Kimaya has not understood something. And it separates the forearm into flexor and extensor compartments. That's another function of the interosseous membrane, that it will divide the forearm into the superior flexor and inferior extensor compartment, or the anterior flexor and the posterior extensor compartment. That's the summary of interosseous membrane and its functions. Should we move ahead? Kimaya, do you have any doubt? Anybody of you is planning to take an Unacademy subscription, please try to take it in 2 or 3 days. Prices are supposed to increase soon, and do use my referral code Chetanya10 in taking an Unacademy Plus subscription. Kimaya, ओके आपका एडमिशन हुआ है अभी फर्स्ट ईयर एमबीबीएस में, राइट? तो एक काम करो, ये वीडियो देखो अच्छे से पूरा. आपका फर्स्ट एमबीबीएस का एनाटॉमी का पहला टॉपिक जो होता है ना, वो अपर लिम्ब होता है. तो ये वीडियो देखने का ट्राई करो, बट आई वुड रिकमेंड कि ये वीडियो देखने से पहले ना 2-3 वीडियोस और देखो. नर्व्स ऑफ अपर लिम्ब की मेरी एक वीडियो है, वो देखो पहले, ठीक है? मेरा टेलीग्राम चैनल ज्वाइन करो, वहां पे ये वीडियोस ढूंढो. वेसल्स यानी कि आर्टरीज ऑफ अपर लिम्ब का एक लेक्चर है, ठीक है? वो लेक्चर देखो. उसके अलावा ब्रेस्ट एंड क्लैविपिक्टोरल फेशिया पर एक लेक्चर है, वो देखो. उसके बाद इस वीडियो को देखना, ठीक है? एंड माय टेलीग्राम चैनल फॉर ऑल ऑफ यू इज @unacademy NEET PG Chetanya. You can join the Telegram channel of Let's Crack NEET PG. वहां से भी मेरे चैनल का लिंक मिल जाएगा. Go to the description. You will find the link to a Telegram channel. There you can see I have recently put up my lecture links. So from there you can navigate to my channel. Okay. And do remember to hit the like button on this. Let's move to question number 197. This is actually question number 35 of upper limb. So 35 questions of upper limb. Let's talk about the articular surfaces of the wrist joint. अरे इसकी बात तो हम already कर चुके हैं. The upper articular surface is the inferior surface of the lower end of radius and articular disc of the inferior radioulnar joint. From the carpal bones, there are 3 carpal bones which will take part in this articulation. That is the scaphoid, the lunate, and the triquetral. Scaphoid, lunate, and the triquetral. So these are the 3 bones that are involved. If somebody asks you what are the bones that are there in the wrist joint, you will say radius plus 3 carpal bones, S and T. Scaphoid, lunate, triquetral. Okay. She looks too pretty, है ना? तो पिसिफॉर्म नहीं आएगी, बट स्केफॉइड, ल्यूनेट और ट्राइक्वेट्रल, ये तीनों बोन्स पार्ट लेंगी एनास्टोमोसिस में. ये तीनों बोन, एनास्टोमोसिस कह रहा हूँ, आर्टिकुलेशन. ठीक है? So is that clear? That's the end of this class. That's everything that we have covered so far. Right? So this is, you can have a look at the articulation. This is the radius bone. Ulnar does not take part. There is the articular disc of the inferior radioulnar joint that will take part, and here you will have the scaphoid, lunate, and triquetral bone. These 3 carpals, inferior articular disc and radius. These are the bones that are taking part. Did you guys like the lecture? First of all, tell me this. Did you guys like the lecture? Right? First, I want to know your feedback about this lecture. This was one of my longest class. So I want to know if you found that the class was worth it? Did you find that the class was too long? I know the class was too long, but was it worth it, the class being this long? So today I'll tell you what we have done. We have accomplished a feat that is, in my opinion, really great. In 5 hours, I have covered the entire upper limb that you will need for your, either it be for your internal examinations और for your prof examinations. ठीक है, I don't say कि 100% इसी में से आएगा, but this will definitely let you pass, and pass छोड़ो, 60 to 70% पक्का आएगा. ठीक है. Besides that, I will say कि अगर थोड़ा सा और करना है, so you can do my video on nerves of upper limb, where I also have MCQs on the nerves of upper limb. You can do my video on arteries of upper limb. Okay, you will easily find these on my Telegram channel. Just go to the links and search for these videos, and you can also watch a video on breast and clavipectoral fascia. Okay, I had covered the clinical anatomy of breast, but I also have a separate video on the clinical anatomy of the breast. Okay, so these are all the videos that you can probably watch regarding this topic, and that should cover it for you, right? That should cover it for you. I will try to make more videos to cover more concepts that may have been left so far, क्योंकि muscles अलग से, hand अलग से, forearm अलग से, ये सब नहीं हुआ है, but this all will be sufficient for you. Yeah, so 35 questions किए. I'll try to have an embryology class as well. So I'll tell you what we have covered again in this terms of questions. ठीक है, एक बार शुरू से लिस्ट करना शुरू करते हैं. I'll just open it in my phone. So for all of you who want to send this to your friends, you can take a screenshot at the end of this, and you can note down which questions we have to do. First question, lymphatic drainage of the breast. Yeah. Second question, clinical anatomy of the breast. Or I'll do one thing, I'll type all of these questions and send them to you on the channel. Is every one of you on the Telegram channel? Will you be able to access it there? Clinical anatomy of the breast. ठीक है, उसके बाद second question ये था. Third question was about serratus anterior. Serratus anterior. Fourth question was winging of scapula. No. Question was brachial plexus. Question was injuries of brachial plexus. Yeah, ऐसे करते करते I think हमने total 35 questions cover किए हैं. I'm not going to write it down right now. ठीक है, बहुत time लग जाएगा. I'll send a list of these questions on the Telegram channel. You guys can subscribe me there, and we can have a discussion on if there are any other questions you feel you need to discuss in the upper limb. So thank you so much for watching the lecture. Thank you so much for being so patient. You watched the lecture for over 5 hours. Yeah, and my plus referral code is Chetanya 10 or SPCM. In case you take an Unacademy Plus subscription, your smaller brother, smaller sister are taking an Unacademy Plus subscription, please ask them to use this referral code. I shall be really glad if you do that. And do subscribe to the channel. Let's crack NEET PG. Hit the like button for this video. Thank you so much. I've already received over 40 likes on this video, so that really motivates me. Thank you so much for that. And once the video is over, I would really appreciate it when the video has finished streaming. Okay, the video becomes available as a recorded session. Please drop a comment at that time for your feedback. And You can subscribe to our Telegram channels. My Unacademy channel is at the rate Unacademy. NEET PG Chetanya. You can access my Unacademy profile in the description, and you can drop a hat. You can dedicate a hat there if you liked the session. And the Unacademy channel for this YouTube channel, the Telegram channel, that the link is also there in the description. It is Let's Crack NEET PG, right? The Telegram channel. And do hit the bell icon for notifications regarding educator is coming live at what time. So once let me walk you through the Unacademy subscriptions that are there. So we've covered over 30. So we've covered 35 questions. It's too much, but that would cover your upper limb for your prof examination. So that's a here. This is the pricing for Unacademy Iconic, and in Unacademy Iconic you get the best of Unacademy Plus, and you get everything that is there included in Prep Ladder. You get everything that is there in Prep Ladder. So you get both Unacademy Plus and Prep Ladder. Yeah, so if you haven't taken Prep Ladder already, then this is the plan that you should take. 1 year plan is for 55,000 and the 2 year plan is for 77,000. Trust me, by recommending Iconic, I am suffering a loss because we get more referrals for the Unacademy Plus subscription. But I would seriously recommend that you take the Unacademy Iconic subscription. Okay, and apply my referral code Chetanya10. And if you are in the second year, you can take it for 3 years also. If you're in the first year or the second year, you can take it for the 3 year plan also. And here again, you will get 9,200 rupees discount, which is a huge discount if you look at it. And it's an additional 10% off. It's already discounted at 44% off, right? So this is a good time to buy a subscription. Prices may increase soon. And for Unacademy Plus, the 1 year subscription plan costs 27,500 and the 2 year plan costs 40,000. The moment you apply my referral code, it becomes 10% less. It's a instant discount that can be applied, right, with my referral code. And you see, you have to purchase it on Android to get a discount. But you can also take it on your desktop. If you take it on iOS, instead of giving you a discount, it will give you free weeks. It will give you free weeks. Okay. So what happens is if you take it for 6 months, it will give you 6 weeks free. Okay. So there this system works, right? And it's better if you take a direct discount instead of taking free weeks. So just enter my referral code, click on apply. There will be a direct 10% discount. So you see this becomes 36,000 from 40,000. And you can also apply credits here. You can see that if you have credits available, so go ahead and watch my free videos. Go watch all my free videos. And even if you don't watch it, put it on play. You will earn credits every day. And you will be able to redeem these credits and you will be able to get a discount. Click on apply and you will be able to get some additional discount here, right? So that's it for today's class. Thank you so much. That's the end of this session. Upper limb first prof series, special MCQ marathon, sorry, special marathon, where I have covered 35 theory questions in a question answer format. Yeah. So don't worry and all the best for your exams. We'll be ending the stream now. If you guys have any doubts, you can send them in. Okay, so there are no other comments. So